Certainly. The board considered 6 items in closed session today. First, the board voted 5-0 to approve the closed session minutes from the regular meeting held on February 27th, 2025. Second, the board reviewed the claim by Sandy Boonenberg against the Tahoe Forest Hospital District related to alleged medical malpractice, rejected the claim as untimely on a vote of 5-0. Third, the board held a hearing under Section 32155 of the Health and Safety Code to consider the disclosure summary for calendar year 2024. There was no reportable action taken. Fourth, the board held a hearing under Section 32155 of the Health and Safety Code to consider the patient safety report for calendar year 2024. The board voted 5-0 to approve the report as presented. Fifth, the board held a hearing under Section 32155 of the Health and Safety Code to consider the risk report for calendar year 2024, and the board voted 5-0 to approve the report as presented. And lastly, the board held another hearing under Section 32155 of the Health and Safety Code to consider medical staff credentialing and voted 5-0 to approve the medical staff credentials as presented.
Thank you.
There's a policy that we're not going to bring through. Do you want me to mention that now?
Policy during the.
You asked if there are any additions or deletions.
We'll do that during your section. Yeah, yeah.
Ted, are you going to pull?
Well, we'll pull that during the consent agenda. Yeah.
Okay.
Yeah. So there's just any changes to the agenda, and then we'll get to the agenda items one by one as far as any changes. So any audience input this evening? No? I was going to give the whole speech around we can't take action, 3 minutes, but if you're just joining us to listen in, then welcome. Any input from employee associations? Not tonight. We do have a special item tonight, item 12 on the agenda, kind of sneaking between our input from employee associations and our MedExec consent agenda, but it is introducing Anna Roth, our new CEO. And I think probably everyone here hopefully had a chance maybe to meet her in person. We have actually some visitors from outside that maybe hadn't, but give you the floor if you want it for a quick hello and welcome. And
I would love my band.
Yeah.
Yes, okay, thank you so much. A microphone, let me turn it on. Okay. So, good evening, board, and members of the audience, as well as members of the viewing public. I am Anna Roth, and I am your new president and CEO of Tahoe Forest Health System, run by the Health District. I want to start with an expression of gratitude. I step into this role with deep humility and really feel very honored to be shepherding and join you all in your mission. This is a profound honor for me. I also want to just tell you a little bit about who I am. I know that you may or may not have read it, but I just want to say I bring decades of healthcare experience, but I started as a frontline nurse, actually even prior to that as a nurse assistant, and I've kind of worked every aspect of the hospital at one time or another, though I wasn't an expert in many of them, but and eventually went on to serve as the CEO of a health system in the Bay Area. My background really has been in community hospitals, and throughout my career, I really focused on equity, excellence, and inclusion. And that includes, importantly, of the community and of the staff and of the board. If I may, just provide a couple of early impressions. I've been meeting with some of you, and I look forward to meeting with the rest of you in the coming weeks. I just want to say that it's very clear that this is a place sort of grounded in commitment and dedication to service to the community. I have been met with just an unmatched level of commitment, compassion, and excellence. Many people have been so excited to show me their vision boards and a lot of the improvement you're working on. And there's just a very palpable, strong sense of pride, both in the system, but also in the community, and a very deep connection. I think initially, sort of as I've been talking with many of you, very similar to what other systems are facing or looking at. I think some of my early sort of areas of focus are thinking about how I can support all of you in enhancing access to care. I think access is a really complicated problem, and so I think been hearing a lot of really great ideas from all of you, and really looking forward also to hearing from the community about what they would like to see. Finally, I think that we are looking forward into a very changing, ever-changing landscape in healthcare. So I am here to help, to join, to greet those challenges and opportunities with you, and I look forward to being with all of you for many years to come. I want to close with some appreciation to all of you, to the board for trusting me, to the system. I actually, the board, I will say, had a very comprehensive interview process, and many of you actually, and many people I met during that process. So I just want to say how much I appreciate the opportunity to be here with all of you, and how much I look forward to the work ahead. So thank you. I'm happy to answer any questions. And if you see me in the halls or you see me in town at the coffee shop, I've found that there's a lot of work that goes on in the coffee shops.
There's only one or two of them. Yeah.
Well, but if you do, I would love for you to introduce yourself, and I would love to meet you. So thanks so much for giving me the time. I'll yield back to the chair.
Absolutely. It feels weird introducing you now, because it feels like we've known each other forever. We meaning the board, right? It was a long process for sure, and glad that you're finally here. But also it speaks to your character. I think that your absolute personality, that you quickly get to know people at their core and connect with them, and so it feels like you've been here for quite some time. But glad it's officially here, and welcome. And now, Dr. Koch, our med-exec consent agenda.
The consent agenda. I apologize in advance. So, once every 2 years, every policy has to be renewed.
Once every 2 years, every policy has to be reviewed, and this is a large swath of that. And so I'm going to just do a little summarizing here, if that's all right. There were minor changes to AEOC 17, which is an emergency operations plan. Specifically, attachment G was added and emergency phone lists were updated. A natural gas failure backup sources were added for both Incline and Truckee. An Annex 9, emergency water and wastewater curtailment, was added. And then there were some clerical corrections. So that was the first policy that has some significant changes in it. The second policy that has some significant changes is the Emergency Management Plan AEOC 14. Performance indicators and monitoring were added, and then assign ICS training, update emergency communication protocols, code triage levels, form a new emergency management subcommittee for clinics. So those were all added to the emergency plan AEOC 14. And then employee health plan DEH 39, there were just some clerical corrections. Medication error reduction plan APH 34, also just some clerical corrections. And then medication error reporting APH 24. There were proactive identification of risks and vulnerabilities. Examples update to include examples of such drugs that may include but not necessarily be limited to diphenhydramine, epinephrine, plumazanil, hydrocortisone, methylprednisolone, naloxone, and phytonadione phytonadione. I don't even know what that drug is. So bless whoever figured that one out. And then they also removed the quotation that said all adverse medication events requiring notification through external state, federal, USP, or FDA channels will be reported according to the requirements of the specific organization. They added errors resulting in patient harm to be reported to risk quality, and they added medication errors to be forwarded to the Pharmacy Medication Safety Committee representative. And then there were some clerical corrections. Two more policies that had corrections also were the QAPI plan, AQPI 05. A health equality statement was added, an RHC reaccreditation was added, and then there were some clerical corrections. And then finally, on the risk management and patient safety plan, AQPI 02, ADA language was added. So the policies that had no changes were the available critical access hospital services, AGOV 06, discharge planning 238, and then one that's we're pulling for today because Alice and Dylan have found some things that needed to be updated, and that will go back through their committee and then come back to us, and that's the Environmental Care Management Program 908, AEOC 908. The Home Health Quality Plan, no changes. Home Health QAPI plan, no changes. Hospice Quality Plan, no changes. Infection Prevention and Control Plan, no changes. Trauma Performance Improvement Plan, Utilization Review Plan, and EMS Quality Improvement Plan Program, no changes. And then some minor changes that we discussed already, and then the next section, policies with risk statements changes, was the death determination policy and the HIPAA and confidentiality policy. And again, just risk statements were added to those policies. There's one new policy, the CME policy and procedures for managing relevant financial relationships, and it's formalizing the requirements that conflicts of interest or financial relevant relationships be put forward. Any questions on any of these?
Dr. Cook, I have a question on page 13. This is the transfer agreements. I understand the transfer agreement list for Tahoe Forest Hospital, but for Incline Village Hospital, it says, I'm just wondering if there's any significance to the order in which you list Renown, St. Mary's, Carson, Tahoe, Carson Valley, and then fifth is Tahoe Forest Hospital. Wouldn't we always try to transfer to Tahoe Forest if we could?
Would
Wouldn't
that
they?
possibly be in alphabetical order? I don't actually
No, it's
know.
not alphabetical.
No, it's not.
No, I don't think.
Jan, yeah.
Hi. No, there is no order that is in. It's just, somebody just placed it in order like that. But obviously, we'll always try to transfer a patient here to Tahoe Forest first, but a lot has to do with patients' insurances. If it's a Nevada insurance, they obviously have to go to a Nevada accepting facility. But we do have transfer agreements with all those hospitals in those areas. Not that we always transfer to some of them, but they're always there in case someone ends up in our area and they would like to be transferred. It's a patient request, too.
Yeah, okay. Thank you.
Any other questions? Comments? Audience, questions, comments?
Great reading.
It was. I'm glad it was digital because I don't think I could have carried it around. It's quite hefty. Yeah. All right, with then, we get a motion to approve.
I would move approval of the MedExec consent agenda.
I'll second it.
All right.
AEOC 908 removed?
Yes, that would be with that removed.
Correct. Thank you for the clarification. Motion and a second. All in favor?
Aye.
All opposed? All right. Approved 4-0. Thank you very much.
Thank you.
Okay. Item 14, consent agenda. Typically, these are sort of non-contentious, non-controversial items. I believe we do have one or two that we want to pull, though.
Yes, thank you. I was requesting that we pull the financial statements. That would be number 14.2.1 for greater understanding of the contractual allowance variance.
Okay. Any others?
Staff would like to pull 14.7.1, Mr. Chairman.
Okay. Thank you. Any other items to be pulled? Hearing none. All right. Motion to approve then with the noted reports pulled.
So moved. Dale?
I'll second that, Alice.
All right. Motion and a second. All in favor?
Aye.
All opposed? All right. Consent calendar passed, or approved 4-0. Item 15, items for board discussion. We've got a few of those tonight. First up, 15-1, Sierra Community House Service Update. With us tonight, I believe, Paul Bancroft. Welcome.
Well, good evening, Chair McGarry and Board of Directors. I just wanted to thank Paul Bancroft, the Executive Director of the Sierra Community House, for joining us tonight. Our Community Engagement Committee was lucky enough to actually watch a presentation from Paul Bancroft. We thought we'd bring it here for the full board as they're doing some amazing work. We are very proud to be partnered with them on some of this work, and so I'll pass it over to you, Paul.
Great, thank you. Let's see, is this on? There we go. Board, thank you for having me. Welcome, it's nice to meet you as well. So my name is Paul Bancroft. I'm the Executive Director of Sierra Community House. I'm also Area 2 elected trustee for Sierra College. And two fun facts, actually three. I was born in this hospital. Both my children were, and my grandmother is a resident in the ECC. So very connected to Tahoe Forest Hospital. I'm just going to briefly give a review of the history of Sierra Community House. Oh, do I have the clicker here? Great, let's see how this works. At our Sierra College board meetings, it's working. Okay, good. I love it. So just briefly, we're going on our 6th year almost as Sierra Community House. We merged 4 longstanding local nonprofits, the Family Resource Center of Truckee, Tahoe Safe Alliance, which was domestic and sexual violence, Project Mana, which was hunger relief, and the Family Resource Center, or the North Tahoe Family Resource Center. And bringing those 4 organizations, we created Sierra Community House with the goal of really having one comprehensive service delivery model serving our community. Is everyone familiar with those 4 previous organizations and now Sierra Community House? Great. This is our service area. We serve California, Nevada, Placer County, Nevada County, Washoe County, El Dorado County down to Emerald Bay, a little bit of Sierra County depending on what roads are open during the winter, and up to the summit. So really kind of following TTUSD's borders while also including Incline Village. And our mission is to connect and empower our community through family strengthening, crisis intervention, hunger relief, and legal services. So I'm going to talk a little bit just about our primary programming, and then I'll talk about some of our partnerships with the hospital, and then have questions where you can call me out if I was incorrect in any of my information. Okay, so our victim support program, that's for victims of domestic and sexual violence and child abuse. We operate the only 90-day shelter in our region. More often than not, we have a wait list for that program. It's one of 7% across the country are pet friendly, and we're happy to be one of those, as we know that one of the primary barriers to a person leaving an abusive relationship is fear of leaving a pet behind. So we're proud to be in that small percentage nationally of pet-friendly shelter programs. We also provide safety planning, education, therapy, accompaniment, whether it's here at the hospital or law enforcement or with various county programs. And we provide legal assistance, whether it's custody, separation, name change, anything that, restraining orders, of course, anything that has to do with safety and helping somebody get out of a violent situation. We also provide support for victims of sexual assault, and as I'm sure you're well aware, SART exams happen in Reno, so we provide transportation and accompaniment to Reno and help folks go through that process as they're receiving a forensic exam, and we provide support to their family as well. And we can discuss offline having a sane nurse here. I've already started that conversation with Louie. Our hunger relief program, so we are a food pantry. We have our warehouse at the airport next to Food Hub. We have a distribution on Tuesdays here in Truckee. Wednesdays we're in Kings Beach. Thursday we're in Incline. We also do delivery to housebound individuals. We participate in a food rescue program. This past year, we rescued 70,000 pounds of food from grocery stores that would have gone to the landfill that have instead gone out into the community and to folks in need. So we're proud of that program as we're building that. And that aligns with legislation that passed in California last January around food rescue. And you can see we have a long list of partners. We're currently serving about 700 households a week through our hunger relief program, and we peak at about 800. Okay, our mediation and legal assistance program. We do family law, landlord-tenant, employment, small claims, and I'll take a minute and talk a little bit about our immigration program. That was what I spoke with the Community Engagement Committee about. We're the only immigration relief provider in our region. The closest immigration attorneys are in Reno and Sacramento, and they have a caseload that could last a career long, and they're not taking any new clients. We are a Department of Justice certified organization, which means that I have staff who are certified and accredited to be able to provide almost full scope legal support as it relates to the immigration process. So applying for visas, citizenship, specialized visas such as the U visa, which is for immigrant victims of crime, T visas, which is for victims of trafficking. All of our services are free, and we're actually, thanks to some generous support in the community, we are hiring to build capacity as we're seeing an increase in demand for services to be able to provide support to our immigrant community. We have done, and in the last 6 weeks or so have done quite a few Know Your Rights presentations, and so those have been targeted for employers as well as community members at large. And so we'll be doing one tomorrow night at our office in Incline. We've had about 200 community members participate so far in those programs. A lot of that is just making sure folks know what their rights are. Employers know what their rights are as employers if they're concerned about their employees. And it also is an entryway for people to get connected to our immigration program. And so we do a lot of screening to figure out where people are in the process. As we know, most immigrant families are mixed status. So while you might have some people with legal residency, you have other folks in the home who do not. And so looking at pathways for folks who are looking for permanent residency, green card, whatever that might be, we can provide all that screening, and then we can do that paperwork for them. And then we can also interact directly with USCIS to help move cases along. A lot of what we're doing in addition is really being prepared. So much like wildfire preparedness, you have your go bag if you need to, evacuate immediately. You have your important documentation, you have your assets kind of figured out. Unfortunately, the same goes for if you're at fear of being picked up or detained by immigration enforcement. What happens if there are children who are citizens and the parents are not? How do you prepare? Do you have power of attorney? Do you have somebody in line that can take over custody of the children? People have assets, making sure that they have those in line so that folks are just prepared. The hope is that it won't be necessary, but you don't know. And we don't know exactly what's going to happen. And then our family support program. So we are a family resource center. So we do resource navigation, public benefit applications, rent and utility assistance, differential response, which is through both of our counties for child abuse prevention and engaging with families who are reported or engaged in the county process. We get called if it's it's determined that the parents will engage with services in order to avoid going down and potentially losing children or foster care going down that path. So really a wraparound approach to be able to provide parenting and other forms of education for the parents so they can get themselves back out of the system if they're currently in it. A lot of the resource navigation is connecting community members to services and navigating systems. So it could be the county systems, it could be the hospital, law enforcement. 80% of our staff is bilingual, bicultural. About half of the folks that we work with are Spanish speakers, so a lot of it is language access and helping folks where language might be a barrier, making sure that they're still able to access resources and get connected in the community as they might need to. And community engagement program. So we do a lot of early learning and parent support. We run the family room, which historically has been at Truckee Elementary, currently is at the Kids Zone, and that's a program for parents and caregivers with kids 0 to 4, so the kind of preschool age. It's enrichment, it's connection, but it's also building community amongst. We have a lot of new parents or new parents to the community who come and really build relationships with other parents. So. We have our Promotora program, which I'm sure many of you have heard of, and we partner a lot with the hospital and with Maria and Lizzie's team here. They are community health workers who are active in the community, working around chronic disease management, again, connecting the Spanish-speaking community to resources that are available. We do a lot of workshops addressing trauma and working through trauma if people have experienced trauma. And they are our dynamic, incredible team that we get to work with. And then we do our violence prevention education, so we provide K through 12 resources to every school, public, private, charter, age-appropriate, anti-bullying, healthy relationships, stranger danger for the youngers, and then as we get older, it's consent and respect and teen dating violence awareness, that sort of a thing. We work very closely with TTUSD and the Incline schools, as well as the various private and charter schools in the region. And that's where I started 17 years ago at this organization. Really trying to move, a lot of our services are intervention focused, but our philosophy is really the prevention side of things and working upstream so we can disrupt some of those cycles. And then, my dream is always that our prevention educators are going to put our domestic violence advocates out of a job because they've done their work and worked with the young generations and they take that with them. Okay, just a couple of stats and then I will stop talking. This is from our recent annual report. So in the last 5 years, nearly 41% of households in the region have connected with our services, whether those are direct services or kids in the schools. We were in front of over 5,000 students last year. So really having a strong connection within the community and with a lot of community members. Over the past 5 years, we've distributed more than 1.5 million meals in the community and provided over $2 million in rental and utility assistance. So that's another big program we have in partnership with MARTA's Fund, NTCA, TOT, and TBID funding to ensure the workforce, folks who have a challenge and need a little bit of help to get across that financial bridge and they don't lose their housing, we can provide one-time rental assistance as well as utility assistance. Okay, just a couple other stats, and then I'll be done. Last year, we provided over 12,000 services to 8,000 community members. We had about 500 calls to our helpline, which is primarily for folks in crisis, but we do get some folks asking about skiing conditions because it's an available phone that somebody's going to answer, and it's somebody always local 24/7. We had 327 community members access 2,500 victim support services, so that's our domestic and sexual violence programming. So, as I'm talking about the services we provide, I constantly hear, but Tahoe, Truckee, it's perfect. Nothing like this ever happens here. And it absolutely does. And sometimes it's even harder to access services because there is this feeling that we live in a postcard and that these things don't occur in a postcard, but they do. And last year we provided emergency shelter to 76 community members. Real quick, we have a couple of different partnerships currently with Tahoe Forest Hospital. We have our Community Health Access Pilot Program, which is working with Maria and Lizzie's program, and Hillary now, in connecting primarily Spanish-speaking clients or consumers here in the hospital with other resources in the community that they might need in addition to what is happening here. We have an MOU with the hospital around our DVERT and SART, so when somebody presents in the ER with victimization of domestic or sexual violence, that we have a policy of connecting and making sure that we're providing accompaniment and vice versa if somebody comes to us to bring them in and ensure that they're receiving medical attention. And I think that's it for now.
That's all. then.
That's all.
I've got a couple of questions.
Yeah.
if I could. Our Truckee Rotary Club just today announced, our president announced, we're going to up our monthly contribution to Sierra Senior Services for Meals on Wheels. from
Great.
$1,000 to $1,500.
Mhm.
What's your connection with them and your program?
Yeah, we work very closely with Sierra Senior Services. Their folks through Meals on Wheels are receiving prepared warm meals. A lot of their clients they receive our food bags from our distribution, which is generally a week's worth of food. So it's supplementing the food that they're getting from Meals on Wheels. We also provide rental assistance to seniors. A lot of the programming and funding that currently exists for rental assistance is targeted for workforce housing or the workforce, and seniors are not a part of that. So we have a pot of funding that's available for when seniors need that financial assistance as well. In addition, the advocacy side of things. So when their Sierra Senior Services is visiting, doing a household visit, and needs might be identified by that senior, getting connected to resources or other services that are available in the community, they can connect with one of our advocates, and then we will reach out. So
Okay.
those are some of the ways. Yeah.
Okay. One other question. I've heard rumors, of course, there's a lot of pronouncements coming out of Washington DC right now.
Yes,
that
there are.
Keeping you guys on, I'm sure, like everybody else, on uneasy, uncharted waters. I've heard rumors that some Hispanic families are not letting their kids go to school or go to programs for fear of getting picked up, or others. It's all anecdotal to me. How do you see what's going on in the community right now?
That's tough because it is anecdotal. And we have heard similar, for example, I want to say a month ago, there was ICE presence in Incline on a Thursday night. That next Friday, there was about a 25% absentee rate in Incline schools. That was immediate fear following. We have heard of community members who are less inclined to come to the hospital for services, who we've heard through the partners of the school district, of families who are even afraid to engage with Sierra Community House just by fear of a system and what system that might represent. And so I'm sure we all are aware that kind of early on there was various rumors that ICE was in Tahoe City or that they were in Truckee, and we've done a lot of work. And Ted and I have been in several meetings where with various community partners and stakeholders talking about how do you verify before texting or, letting people know that ICE might be in town, really making sure that they're not. I think that it's gotten a lot better, and folks are not quite so fast to say, oh, there's an unmarked Suburban across the street, it must be ICE. There's more verification happening, which has decreased kind of that level of fear. Not to say it's not there, it's very real. We have a lot of folks who come into the office just wanting to know how they can protect themselves, how they can protect their families, and we talk through, all the different channels that they can engage with that don't put themselves at risk. One of the things that we're keeping an eye on, and like you said, things are changing really quickly. And historically, green card holders, barring committing, violent crimes, were protected as a legal permanent resident. We've seen some pretty high-profile cases where green cards have been revoked without due process. So we're just watching, because historically we would say, you're fine, don't worry about it. But we can't say that now because that's starting to happen. So we're keeping an eye on that. Our immigration specialists are keeping an eye on kind of what's happening at the national level to see, okay, if this becomes a trend, then we need to adjust kind of how we approach our conversations and our education with the community. So,
Okay, thank you.
That was going to be my question too. Reflecting back on the conversation that we had at the Community Engagement Committee, last month, but I'm happy to hear that the temperature, the anxiety level is going down a little bit, but it seems like then every day it gets checked back up again, because it's certainly a roller coaster ride. But I can't thank you enough for what you and your organization do. I mean, it's so needed and so important in this community, and I can't imagine where people would turn if you weren't there, so thank you.
Well, thank you. Yeah, go ahead.
Paul, again, I want to reiterate that appreciation for what the community house does. I was at a meeting this morning, and one of the things that came up is that a lot of the residents, and especially the older ones who've been here a while, don't really know about the services that are provided. So I don't know what you're doing as an organization to really get it out there, the services that you can provide and who you're already partnering with. I know that they had talked about it. At some point, we used to have a reference sheet of all the services that were provided in the area, but I think that has sort of fragmented, and there's not just one place. So if even we knew that the community house had that list of all the services that maybe as an immigrant I could come to, or maybe as a mother, a single mom with a young child and not knowing what's available to me. So is that something that maybe the community house might think about, or?
So to your first question about what are we doing to inform the community, I mean, we're doing everything we can constantly with every type of communication and media platform possible. And yet I'm always amazed when I run into somebody who says, "Oh, what happened to Project Bahana?" or "We didn't know you existed." So yeah, it's tough. And we really rely on our board and volunteers and staff and folks who are aware and who, we really see as ambassadors of the organization to help spread the word. I think that Tahoe Truckee Community Foundation is a great resource for the community if they want to get connected or have that resource guide. I think they're kind of the closest thing with the community collaborative as a part of that to already having that. So without wanting to duplicate services, at this point, I'm not going to sign us up to create a resource guide, but I do think that it's always good to hear that those efforts, we need to continue the efforts of getting the word out about the services we provide and make sure. So we haven't reached everybody quite yet, but we're working on it.
Well, thank you for doing that.
As a follow-up to what Alice is saying, often people will seek out the hospital as a point of refuge.
Mm-hmm.
And so the more we're aware of, where the diversions are, where we can send people, the better equipped we are to be of help in that moment. So I encourage us to get some sort of a list together, because people will come here.
Yeah.
Well, what are your sources of funding?
Great question. So our overall budget's about $5.2 million. About 70% is grant funded. So about $2 million is federal funding, all of which is precarious at the moment, precarious at best.
That's going to be my next question.
Yeah. And then the rest is local, foundation, county, and then the 30% remaining is family foundations, individual giving, events, fundraising, donor cultivation. So, and I didn't mention that we have 5 offices or 5 sites. I did mention our warehouse at the airport. We have an office on North Woods, right across from Truckee Elementary, where the radio station is, and then another one on TTUSD property next to the Kid Zone. It used to be the Family Resource Center of Truckee. Mm-hmm. Then we're also in Kings Beach and in Incline. So,
okay. But as we've all acknowledged, who knows what tomorrow's going to look like? But that's a good percentage of funding that is uncertain at this point.
Absolutely.
Okay.
Mm-hmm.
Okay. Looking to the future, if resources weren't a concern, which I know they keep you up every night, but what are the biggest barriers to the work you're doing, or where do you feel we as a community in supporting your work it could have more impact? Where do you feel you're coming up short for any number of reasons, not for lack of effort, but
sure. Getting the word out.
Yeah.
Making sure that more people are aware of our services. I think a lot of our services, like I said, are for, people come to us when they're in crisis, but they're not thinking about us when they're not. But a lot of our services are bringing community together. We have a lot of events that are community building. We do a lot of workshops and early learning programming. So just making sure that folks are also aware of those programs in addition to the more crisis-oriented programs. I think our hunger relief program could be expanded, our ability to really maximize on the last year's legislation requiring food rescue. It's, our hunger relief's a team of 4 who are providing over 700 households with food weekly and also doing all the food rescue. So being able to work closer with the town and maybe have some dedicated resources to just focusing on the food rescue, whether it's from grocery stores. There's some new programming that's coming out that will connect families in need with local restaurants. We don't currently rescue food from restaurants because we don't have a kitchen facility. We don't have a use for 25 gallons of mayonnaise. And so when restaurants have excess, there's a new app that's being enrolled, and we're just starting to have conversation with the town Truckee about that will allow families to directly connect with local restaurants, which will be great. So, but that's in addition to all the other things we're doing. And with I am anticipating, I'm eager and afraid to see the May revise that comes out from the governor's office and what the budget for California will look like. We're very much tied to that as well, I'm sure, like you are. And so, my dream is to not have to worry about that kind of stuff and really be able to focus on the programs and the work we're doing. And right now, it's hard. In my role, usually is to be visionary and to be thinking outside the box and to be growing programming and being innovative. And it's really survival mode at the moment. So looking forward to getting out of that phase and back at the 30,000-foot level. So I don't know if that answers your question, but
No, it absolutely does. I was just trying to get a sense of as we think when we put our visionary hats on as well. Clearly.
But I did mention one dream I do have, and that's having a SANE nurse here, so we don't have to take victims of sexual assault to Reno. We have, and I don't have the data with me, but we do have a fair amount of victims who, when told, they come to us after a sexual assault has occurred, and we say, okay, well, the forensic exam is in Reno, and they say, no, thank you, I'd rather not have to go down to Reno to do that. We might be able to get them to come to the ER for a basic exam, which is great too. But so much is lost when the forensics exam does not happen and a rape kit is not collected. So that's a very real dream that I have that involves Tahoe Forest Hospital. So happy to talk about that more.
Yeah, and in closing for me anyway, your comment about, we live in a postcard, I think most everyone would agree. But the numbers you share are staggering. I mean, I'm just looking at the 1.5 million meals. I mean, it's a lot of meals for a small town.
Yeah.
Especially a small town that a perception of wealth and health. And so just echoing the other comments and gratitude for the work you guys are doing and look forward to probably, I think, through the Community Engagement Committee and exploring ways we can support. So thank you.
Great. Thank you. I think in your contract, it requires service on a nonprofit board, so we can talk later about that. Oh, perfect. Oh, good. We'll talk. All right. Well, thank you so much. I really appreciate it.
Thank you.
Paul, one
Appreciate it.
last quick question.
Yeah.
What level of volunteerism do you have, if any?
All across the board. Right now, we have our primary need is in our hunger relief program, so packing food bags at our warehouse, being present during food distribution, so making sure the food gets out, all the way up to helping in our shelter and working in the classroom. So it's a big continuum of opportunity. So all that information's on our website if you're interested. But our need right now is really in our hunger relief program.
Okay.
Yeah.
And before you jump, real quick, just checking, any questions, comments? All right.
Okay.
Well, thank you so much.
Thank you.
All right, next up, item 15.2, Community Health Index. And we have Maria, Megan, and Lizzie, who I haven't seen in quite some time. So welcome. Thank you for being here tonight.
You three can have some space here so you can.
Oh, no, we kicked you out.
She just got here.
Okay, Megan, you're sitting where it says Chief Executive Officer, so.
How's it feel? How's it feel? In the hot seat, yeah.
All right, well, thank you so much for allowing us to present tonight. My name is Maria Martin. I am the Director of Community Health, and I will be presenting with Megan Shirley, who is our Population Health Medical Director. Are these on? Yep. And Lizzie Hennessy, our Population Health Analyst. And we're going to kind of give you an update on where we are with the Community Health Index. So this is our agenda for today. A quick overview of the index. We're going to talk about our successes. What have we accomplished so far? Go into a little bit more detail about the work groups that are formed and are starting to produce some results. And then talk a little bit about some constraints, sum it up, and then we'd be open for a discussion.
Okay, so thanks for having us. Again, I'm Megan Shirley, and we gave a somewhat similar presentation to you guys, I think last fall, when we were first kind of launching the Community Health Index. So some of this might be familiar, but we're going to give an update of what's happened since then. As everyone probably knows, one of our strategic pillars or peaks for the health system is community, and that was a shift that came about in 2023 as directed by the board, and that was a shift from growth to community. And so with that came the need to have a way to measure how we were doing on that goal. And on the left there, you can see the statement is that we aspire to be an integrated partner in an exceptionally healthy and thriving community. And so I think Louie and Dr. Evans came to us in the community health department and said, how are we going to measure how we're doing at this? So we kind of, got our heads together and did a bunch of brainstorming and looked through potential models that already existed, indexes that could be out there already that we could adopt here at Tahoe Forest, and ultimately decided that none of them really fit our community because of some of the unique features that we have. 2 states, multiple counties, we don't really fit into a county track and that sort of thing. So we decided to kind of build our own index, and so that's what we've called the Community Health Index. You can see that on the right. And after, again, more debate and brainstorming, we selected 15 different topics or metrics that would be included in that index. And so these are things we value as important to reflect really the community health. It is not all-encompassing. There are so many things that we would have loved to include in that, but we had to kind of pick a few to start with, and so that's where we landed. We've grouped them into priority areas in that kind of middle column. So there's 5 priority areas, and then within each area, several metrics. This also kind of reflects some of the priority areas that have previously been identified in our community health needs assessment data, so that was helpful that those aligned. I'm not going to read through all the metrics on the right, but we'll talk about a few of them that we have actually started working on with work groups. What I will say is we had to determine what our goal would be, right? So we're able to collect data on all of these things, and I'll talk about our data sources, but then we also needed to decide, well, this is where we are now, how are we going, where are we going? What is our goal ultimately on these categories? Should we adopt a state goal? Should we make our own goal? We want to increase everything by 5%. What would that look like? And so we decided to adopt the Healthy People 2030 goals, which is a CDC national kind of, or maybe not CDC, but a national recommendation. And so that is the goal that we're aiming for in all of these areas. And you'll see a bit more on that on the future slides. Data sources, so some of these are coming from internal data. So we're pulling data out of Epic and our own EMR, and we're using that as our source. Some of this is coming from the California Healthy Kids Survey, which is done through the school district. So our youth information's coming from that, which I believe they survey 9th and 11th graders. Some of this is coming, some of the mental health is coming from a UCLA loneliness index and CATS Amsterdam, which is a foundation that has surveyed our community, and so we were able to get their data on our area. And lastly, our own community health needs assessment, which we do every 3 years. And we're in the process of doing one right now. I think I'll leave it at that with the overview.
Okay.
Yeah.
Great. Okay, so wanted to just talk about like the successes that we have achieved so far. We have 2 groups that have launched since November, and we're going to go into a little bit more detail about the composition of those groups, and the process that they have followed and where they are. But these other factors down below are things that are also really contributing to our success. And the first one I want to talk about is engagement. Is what we are finding as we have embarked on this process is that people are really excited about it. Our own staff is excited about it, the community is excited about it, and so we're getting, at least with the work groups that we've launched so far, a lot of enthusiasm about wanting to participate. So that has been huge for us. We are structuring the work groups, the ones that have started, with a charter, so that we really feel it's really important that everyone understands what's expected. We have big goals to achieve, and we really need strong engagement. And so by having a work group charter, people come into the work group knowing what their time commitment is, what our goal is, and how they are viewed, and what we're going to expect from them. The third thing, population health approach. So as a health system and as providers and health educators, we like to work one-on-one with people. We like to, if you think of population health or public health as a pyramid, we like to work at the top. That's where we're comfortable. But we're trying to introduce to all the groups to think broader and to think about ways that there may be system or policy or other changes that would affect a broader number of people, and that we can start there and then work up to maybe some at the highest risk that would be lower populations. Megan mentioned our community health needs assessment. So we're in the process of completing it now, and we've adjusted some of the questions on that to reflect more data for the community health index. And specifically, we changed the questions around mammography and colonoscopy to be able to assess, are you up to date versus have you ever been screened? And we added those UCLA loneliness scale questions to our needs assessment as well. And if this works, we're going to be, let's see, how would I do this one? No, maybe not. I don't think I have a mouse.
I wonder if Sarah can do it.
Sarah, I don't know if you can
To pull up the
click on that
dashboard?
link for the
Yeah.
dashboard. So this is not live yet, but we've been working with marketing to create a public-facing dashboard. We think it's really important as we're embarking on a community change that we want to show the public what we're doing. So this is what it looks like, and if we scroll down, and there's a really nice image that marketing came up, which we love. So this is the 5 priority areas, and they're not all live. The only one that's live right now is the chronic disease management, so we can click on that. But we tend to use this structure to report out on all the things that we're doing. So for chronic disease management, it gives an overview of what our goals are. We have 2 projects under chronic disease management. If you can click on the diabetes one, and we're going to talk more about this work group. It'll talk a little bit about why it's important. Why do we think diabetes in control is an important metric for community health? Talk about what our goal is with links to the Healthy People goals, and then show kind of where we are. So we have 2 years of data on this one. We can see the blue is the number of patients. This metric is pulled from Epic that are in control. The red are patients with diabetes that are out of control, and the gray are patients from our records that we do not have results on. So this will give us pictures, and we'll be continuing to update these at least annually for all the metrics. And then if people want to learn more about it, they can click kind of on the side about the work groups and projects and things like that, where we're still building that out. And then the last thing in terms of that has set us up for success is the work group structure. So we've really adopted the management systems approach. We've used impact and effort metrics to actually help us determine which metrics to start with. And the other thing is we are trying to leverage things that are going on in the health system already. So where there's momentum, at least for these first work groups, is really trying to align with things that are going on so we can work collaboratively to reach these goals.
Can you give an example just on the work group structure? Like who, is that 2 people, 10 people?
Oh, we're gonna get that.
Okay, cool.
There's a lot of information on this slide, so we do, this is the only handout that we brought. Okay, so that's
It's the last class, there's
Oh, perfect.
Thanks, Sarah.
So we, as Maria mentioned, one of our successes is that we have launched 2 work groups, and they're really different in their approaches. One is fully internal. It consists of Tahoe Forest staff 100%. It's facilitated, coordinated, follow-up, everything is Tahoe Forest staff. The other was started with our community partner, the Community Collaborative, mentioned by Paul earlier, and it's multiple partners at the table. The hospital is just one of many. So we have 2 different groups that launched on the same time. Both groups are following this timeline. So organically, just so you know, we're in step 3 for both of those 2, but they both started with this initial outreach and a conversation to really secure that person who can be the champion for this metric. That takes a couple months to really make sure this person is aligned in that vision and understands their role and responsibility, feels comfortable facilitating a multidisciplinary group and helping to advance in a really respectful way the work of that work group. Once we've identified that champion, we meet with them a couple times to make sure we're very clear on the roles and responsibilities, and then collaboratively we identify additional work group members. We want a broad lens. We want unique perspectives all convening together to really advance these metrics. So that takes a couple months, believe it or not, up to 3. Months 3 to 4, you're meeting with this work group. You're really setting that culture within that work group so people feel comfortable speaking up and sharing their unique perspectives. They commit to the charter that Maria mentioned, and then they spend the next couple months digging into what is our current state. So that means, what are the assets that we currently have? What are the barriers to accessing those assets? They do a strengths, weaknesses, opportunities, and threats analysis. So they're just continuing to gather more data to get a really comprehensive picture of what can we do to advance this metric. That also means further digging into data. So we have that high-level data. We have those SMART objectives, reducing A1C, for example, or increasing those in control. But we need to further disaggregate that data. We need to figure out who actually is at risk, who's more likely to have an A1C that's out of control, so we can tailor our programming to reach those who are most vulnerable. So you can see that's taking at least 4 months. The good news is, with both of these really different groups and different makeups, they're both within this intervention planning stage. That is doing a little bit more research. What works in other rural communities? What works for this group who we know to be more at risk? How much is this proposed intervention going to cost in terms of people and time and potentially infrastructure? We are always looking at this from a lens of how do we measure your impact. And impact can be financial, it can be improvement in a health metric, it can be, there's a lot of different ways to measure impact. And we just want people to think big, but also, okay, we actually need to measure that we're having some kind of change here. What we're hoping to be in the next couple months is these work groups are reporting up to the Community Health Index Steering Committee. That is the 3 of us presenting now, and Louis and Dr. Evans, and then Kelly Downs and Jeffrey Cisneros. So, and then further presenting to other groups as is appropriate. For example, the Primary Care Committee, community partners, and then the key to that is not just to present, but to get feedback and incorporate that feedback into the intervention. We want to hear these different views. We want to hear other barriers that we haven't thought of yet, so we can further modify the proposed intervention so that we are successful once we get to the rollout phase. It's a lot of meetings and conversation. Step 5, really this is a PDSA cycle, if you're familiar with Plan, Do, Study, Act. Further refining, and then ultimately at the end, in a year, we can hope to reflect on all that we've done. We've rolled out an intervention, and now we're saying, how can we sustainably grow this, or do we actually need to scale it back, or do we just need to start with a different intervention? So, I mean, as public health professionals, we're constantly in a cycle of evaluate, measuring impact. Let's fix it, let's measure it again. Are we doing what we wanted to do? I mean, that is public health at its finest.
All right, thank you, Lizzie. So we are going to dive in a little bit more to the A1C work group, and so hopefully we'll answer some of your questions. And so this is the first work group that launched. I think that it was chosen, one, because we did that impact effort analysis and matrix rather, and we also found that we weren't too far off the mark of meeting our goal. And we also had a champion who was really excited about leading the group. So that was Dr. Allison Semraj. So she's endocrinologist, and so she's been the champion of the group. She then helped us identify what other members should be present and participating to give all that really well-rounded approach to talking about what is the problem here? Why do we have diabetic patients who are not in control, and what can we do about that? So we haven't listed names, but these are some of the departments that are now represented within the work group. I'd say there's about 10 people that come to the work group meetings, but we've got representatives from community health, from dietary, we've got some people from care coordination. So for those that don't know, care coordinators are nurses and other healthcare team members who are reaching out to higher acuity, higher complex patients that really need a little bit more TLC or hand-holding in their process. And so we're getting their input into why are people out of control. We've got business analytics involved to help us look a little more at the data and what we might do. Primary care representation, obviously we've got a lot of our patients coming out of that type of environment clinically. Wellness, which offers a lot of education in our community. And then our community health advocates, which is that really good tie-in to our bilingual, bicultural community. And they are trusted in that community, and they can help us with communications and make sure we're thinking of everyone's perspective. The work group formally launched in November, so right before Thanksgiving, right before all the holidays and everyone taking time off and making it even harder to schedule meetings. But it's been a really productive group. We've had 6 full meetings with everyone present, and then 8 additional kind of side meetings with subcommittees and other people working on the issues that come up, that, okay, we need to look into this, who's gonna do that? And they've definitely made progress. So as Maria and Lizzie already talked about, it's been really important in this first group, since they've kind of been our guinea pig or pilot, to make sure we're setting up the structure well as best we can. And so really making sure we've got the charter, and so that was part of this work group. You know, a whole meeting talking about the charter, talking about what can we expect from one another, what are the norms of this group, how are we going to work together collaboratively. I think that's gone really well. I think that group feels safe together, which is important. And then defining the current state. So that's some of that SWOT analysis. What are our current resources? Who's using them? Who's not? Why? Internal resources, external resources. Like, let's get everything out. Like, what do we know? What do we know that we have? And also, what do we know about the data we're looking at? And so as we started to look into that, it kind of brings us to our next slide. Yeah. So when the group did start to look more at the data, one of our data analysts was awesome at kind of looking a bit more closely at what had already been pulled out, and we saw that the way the report kind of have been written, and this is based off of this, it was written this way for some reasons kind of outside of our control. Our group that came in as out of control, so a diabetic patient who was out of control, actually included a lot of patients who actually didn't have an A1C test. So we realized that maybe the proportion of patients who are out of control is actually much smaller than we think it is, which is good. But it also led us to this new problem, one of the problems that we don't, our data extraction process from Epic is not perfect. And so there's probably a lot of our diabetic patients who actually have an A1C test somewhere within the electronic health record. We just can't pull it out easily. And so while that doesn't seem like a super important intervention, it's actually a quite important realization for this work group and all the other work groups, that's going to be a bit of a problem. We'll have to think outside of the box on how we can get accurate data out. So hopefully that makes sense. And so that's on the right where Maria had kind of showed before. We actually have 3 categories now. The blue would be our diabetic patients who are in control. We like that. And now we've got not just the people who are out of control, which is red, but we also have the people who aren't tested. And so you can see the untested, which is gray, is actually a pretty big proportion. So some of the work team members are doing chart review on all those patients, and they're spending time looking in our electronic medical record to discover if they indeed do have an A1C, and is it in control or out of control. So we're gonna get the information, but it's been time consuming. Some other
You're
things.
looking for current A1C?
Within the last year.
Within
Yeah,
a year,
the last
okay.
year. Yep. Some things that the work group has found in looking at the data more closely, more of the patients are Hispanic, more of the patients are younger than Medicare age, more of them are male, more of them are likely to have what's categorized as a dire visit, so a visit to the emergency room, an urgent care, or have been admitted. And it doesn't actually align with patients who are well-controlled, doesn't align with those who've had more primary care visits, which might be a little bit against what we would have assumed. So that's some of what we've learned thus far. And then one other thing we've learned, we did look at some of the zip code analysis, Anna. We were talking about that the other day. And so we looked at the patients who were out of control from 2024 and just did a quick zip code analysis. And about 30% of them are from one of the Truckee zip codes, 96161. And about 15 to 16% are from the Kings Beach zip code, over where Sierra Community House has a lot of their resources. So what is the group doing with all this new knowledge and collaboration? So one program that's kind of about to take off, it was presented at the Primary Care Committee meeting earlier this week, is improved education. And so that's the top line, and there's actually two types of education that are being rolled out. The first is a virtual diabetes education class. So this will be happening for patients who were referred into the program by their primary care provider. It'll be Thursday nights for about 1 hour virtual, so hopefully it's more accessible to folks, and they'll be covering different educational parts about diabetes management. And then the second part is the one-on-one meetings with a dietitian. So we're gonna be identifying our highest risk patients, patients who have the highest A1C, and having them connected with a registered dietitian to get diabetes education.
So if things are being done virtually, do we have information on if they have access?
Yes, that's a great question. So that has been brought up as a concern. We want to make sure this is accessible. And so what we're hoping to do, the dietary department is kind of managing this program. What they're hoping to do is have some hubs where people can go and attend the virtual class, which kind of seems odd. But for those people who don't have computer access, that potentially we'd partner with some of our community partners and have a classroom setting somewhere where you can say, if you don't have computer access, you can't get onto Zoom, whatever the struggle is, please come here and we'll have it set up for you.
And is it going to be taught in Spanish?
Great. So they have a goal in 3 months to have them also available in Spanish with a Spanish educator. In the meantime, they're working with IT to get a function turned on where it'll be translated in captions, which is not as good, but it's something.
Yeah, because you have to assume that they're able to read it.
Yeah, exactly. Exactly. Yeah.
Yeah, so the goal is to do simultaneous interpretation, which you can do on Zoom with two different presenters.
Yeah.
Yeah, those are great questions. Second thing, we talked a little bit about this, one of the strategies. We've realized that there needs to be improvement in the data capturing or the data extraction. And so there's other conversations happening outside of the work group now as well about what that looks like for the health system. Health maintenance is a part of our EMR, our electronic medical record, that we're realizing we could be using better potentially. So there's conversations ongoing about that. The third thing down is increasing outreach to encourage and support testing, because some of these people just aren't getting tested. And so the community health lab program was already revamped in January of this year. You guys are probably aware of that. I think that's been a big win so far. And so there's easier to go get labs drawn basically any day, Monday through Friday. So patients are appreciating that. And then we're going to have some of the community health advocates actually calling and interviewing patients who are not tested to try and inquire why. And is there some way we can help you get tested so we know how you're managing your diabetes? And then the fourth thing the group's talking about is, are there things we can do with technology or in the clinics to improve our ability to get a test the time we see the patient, and then we know what's happening, both for management purposes so we can make decisions on medication, but also now we have that data point to use. Great, thank you.
How do you know they have diabetes if they haven't been tested? I don't quite understand.
So they have to be, so for this population, they have to be our patient, so they're already enrolled in Epic as our patient, and they've been given a diagnosis of diabetes by a healthcare provider.
Okay.
So there are a few criteria where they have to have at least had some tests at some point.
Yeah.
And just to add on to that, one other thing is that they're active patients. So we looked at people who had at least 2 visits in the past year in primary care. So this population is a population that we have full control over because they're already accessing care in the health system. We're not it's not someone in the community that has undiagnosed diabetes. We haven't addressed that. It's just our own patients.
So they've had symptoms, they showed up at the ER or urgent care.
Primary care.
Were tested
Primary care.
and given a diagnosis.
Yeah.
Okay.
And also, we hope to capture people who are living here, residents, not coming through for one ER visit, happen to be diabetic, right?
Sure.
So we're really focusing on our core population.
So thank you for that presentation. That was
There's
wonderful.
There's more.
Oh, I know. I know. Just as we're taking this break here, and how do we make Paul's clients your patients?
Yep.
Okay.
So there's our 3 different metrics that we don't have a work group yet, but yes, we have those ideas. But one of the ideas for this Spanish language outreach, and for those who may not have as much tech savviness, is for Sierra Community House to be one of the places where people convene to participate in the virtual diabetes education, which I do want to add is complementary to other in-person Spanish language diabetes-specific education we have been offering now since, I think, 2014. So this is complementary to other in-person classes that are offered for this diagnosis.
And then I think what you're alluding to, Mary, is one of our metrics is currently insured and trying to increase the proportion of our residents that are currently insured. And those are mostly clients of Sierra Community House. It's our socioeconomically disadvantaged population. We haven't started working on that, but we did submit a grant.
Yeah, we'll know on Tuesday.
That we'll know on Tuesday, but we're not holding our breath on that one. It's federal.
Currently insured.
One of the other things that we're measuring under the healthy
yeah.
people is that they have a primary care physician.
Yes.
And so,
Coming up.
Yeah, so the number one there is in our socioeconomically disadvantaged population. Number 1 is currently insured. Number 2, we're going to be looking at has a primary care provider, which is exactly what you're talking about, Mary. How can we get, those folks hooked up to my clinic? Not mine, but maybe mine.
Well, you're the CEO. So.
Well,
For now.
I might
Yeah.
see them. I might be their PCP. Not all of them. And then the last one, number 15, is actually in our entire population, how many have a primary care provider. So, yeah.
All right, is everybody ready to talk about youth substance use now? All right, so our
Do it.
other group is facilitated by our wonderful community partner, the Community Collaborative. Tahoe Truckee was mentioned earlier as being really a conduit to a lot of our social service resources locally. The program director, Christina Kind, is facilitating that group along with her coordinator, Maeve Donovan. And that group started because the Katz Amsterdam Foundation gave $24,000 to the school district, specifically to increase supports for teens and their parents around substance misuse. So it's for families and youth and their parents who were struggling with substance use. So we came into this already having some structure, and the school district invited the collaborative to facilitate that group. They felt like they didn't want to be the sole entity making the decision on what's the best way to reach these people and what's the best way to support our youth we know are struggling with this. So let's pull in our partners. This is normal. We work with the same partners all the time. You can see the members listed up there, the school district, Placer County, and Nevada County Public Health, Gateway Mountain Center, I think you're all familiar with. And then multiple departments in the Tahoe Forest. At the same time, we had discussions with Dr. Chelsea Wicks and Dr. Jonathan Lowe to be champions for this. So just a lot of things really convened at a wonderful time with the index launching. We had the funding from Katz Amsterdam. We had Dr. Wicks and Jonathan Lowe reaching out and wanting to be engaged. So that launched on November 7th, really right around the time of the A1C group. Again, following that same trajectory. We've had 7 full work group meetings with multiple partners there. And then, as you can see, pretty much for every full work group meeting, there's some subcommittee that's working on this outside of that full work group meeting. As opposed to having a charter, this group has found the community guide framework. So this is really a whole framework that is specifically for youth substance use, and we've all reviewed this framework. We've agreed to abide by these guidelines. It's really organizing our decision-making process. But again, you can see we've done the same thing: SWOT analysis, mapping the system, additional data capture. So moving right along. The next slide has the data. So this is all of our youth data we're really pulling from TTUSD, so Tahoe Truckee Unified School District's biannual California Healthy Kids Survey. So our baseline is the 2022-2023 school year. The numbers we're looking at, these are 11th graders and their 30-day use. So if a youth had used any vape product, it can be marijuana or a cigarette or tobacco, nicotine related, as long as they're vaping. If they've used it once in the last 30 days, they're reflected there. For binge drinking, it's 5 drinks within about a 2-hour period. So they just take like a sitting. So 14% of our 11th graders had what's considered binge drinking, 5 drinks in one sitting, at least one day in the past 30 days. What's important about these numbers, yes, we're elevated from the Healthy People 2030 target, but they're also underreported. So we know anecdotally, and some of the data we've been gathering, is that our use far exceeds the numbers. So if you think these are elevated, really these are actually low for what we think is actual use in our community. We defined early on that as a community, we're really heavy on the prevention side. We, as a health system, fund Alcohol EDU, which is an alcohol program in the school district. We fund some other opioid-related curriculums in the school district. The school district itself has a Safety First program. There's a lot of work, is my point, going on the prevention side. However, we're really lacking in the treatment. So we're good on prevention. We're somewhat good on some intervention stuff through Gateway Mountain Center and some other local resources, but it's the treatment for youth specifically that is really challenging for our local families, and it's fractured and just difficult to navigate. And then to put on top of that is, maybe you all keep up on the latest verbiage for youth, but the trends and the names change so quickly, it's hard for our pediatricians and our family practice providers to even know the right word to ask to get an honest answer from a youth. Parents have no clue. So just even knowing, like in our needs assessment, we're saying, oh, I've used an e-cigarette. I mean, we are not surveying youth, to be clear. But they might be, no, I'm not using e-cigarette, I'm using a Zyn. You know, so they can honestly say no, but they are very well using. So anyway, those are some further observations in defining the problem. So what are we doing? Honestly, one of our interventions is getting more information, because right now we don't really know what resources are specifically, and by that I mean because we aren't asking the question the right way. So we're going to do 2 surveys. One's a little bit more simple through our school district wellness centers. There's wellness centers in every middle school and high school, and that they're already working on that survey tool. And then we are working with Dr. Wicks and Jonathan Lowe on doing a survey in our clinics, and we're working through that with the ethics committee and what exactly is that going to look like. This is part of a quality improvement survey, supporting their board recertification. And another shout out to the collaborative. We know that we do not have a single place online that summarizes all of the local resources that we do have for substance use. So the community collaborative is, at this moment, creating a webpage that will house those resources. We're still working on parent education. I find it interesting we chose microdosing. I think that was not the best term to use in how we're trying to educate parents. But anyway, the point is small bits of education for parents, probably via social media through Aries, which is the TTSD portal that they need to re-up their students, say yes, they're going to go to school next year.
I did misread that. I thought you were educating them on microdosing.
Yeah. I know. I read that, but I already
which is all the rage right now.
But you all get the point. And then honestly, as a health system, we have services, but we need to clarify how can youth access the services that Tahoe Forest is currently offering, such as substance use navigation, our medication-assisted treatment program, and nicotine cessation, which are 3 different departments. So we're working on a single handout to help youth access those services. More to come.
How challenging is it, we talk about parent education, I think we talk about diabetes, we talk about nutrition. Oftentimes the person managing diabetes isn't necessarily the one doing the grocery shopping. Or, in our case, in this town, parents may actually be binge drinking as well. How challenging is it, or how strong is that approach to try and engage not the individual as the unit of health, but the family as the unit of health?
Well, I know with our diabetes self-management program that a family is always a part of that conversation, and those caregivers or peers or spouses are invited to come participate in that education. And I imagine that the virtual will be the same approach, inviting the family, because that is a unit. I mean,
Yeah, that's true. In our diabetes prevention program, couples come together.
Okay.
Cool. As far as the cultural shift, that's a whole nother issue that we're just kind of starting to embark on that path, is that right? Parents could be saying you shouldn't do this, but they're doing
the same thing. Or we've had issues that we get reported on from local law enforcement of parents hosting parties for the kids. And
Yeah.
And I think the collaborative recognizes that, even though it's a youth-focused group, that we have to educate the parents. So a lot of it is going to be educating the parents on what trends are happening, what to look for in your youth, what resources do we have locally, and so, tackling it from both angles. Like the flyer that we've talked about will probably be handed out directly to students at school, because we also have heard from the wellness liaisons there that kids are scared, like they don't want somebody to know that they asked for the flyer about the cessation program, right? Like there's this stigma around it. So I think we have to target each audience, differently, but intentionally, because it's got to be,
Absolutely.
everybody.
We're pleased to see on the next slide, culture is one of our constraints.
Can I ask a question before we move on to that? Under the youth substance work groups, you've decided to follow the community guideline framework. Is that a tried and true tested framework that you're using, and where does it come from?
Actually from the CDC.
Okay.
So I have noticed, just since this work group launched and with the recent changes, that I'm actually unable to access some of the community guide frameworks. They have multiple frameworks. For example, accessing mammography is one that I've continued to try to find, but it is through the CDC, and it is a vetted, yeah, do you have it printed out, actually? Wonderful.
Oh, good.
Yeah. Yeah, and so what's great is they're really specific to the issue. So the one we're following is specific to building coalitions and partnerships specifically for substance use, for youth. So yes, it is.
I just wanted to make sure that it wasn't something that our community came up with, just randomly, but that it's been proven that these things will work.
And I can send you the specific.
A question, if I could. I've been on the board 12 years, so I've seen at least 3 community health needs assessment results, which consistently showed 2 anomalies. Number one, that we're a far healthier community than the statewide and national average. I see it in my friends. The people who live here typically are skiers, bikers, hikers, swimmers, they're outdoor, energetic, athletic people. But the second anomaly was that we drink 50% more alcohol than the statewide and national average. So it should come as no surprise that the kids see the parents, that they're going to do what they do. Isn't that true?
Yes.
Yeah, so it would seem to me that somehow focusing on the parents hopefully will then filter down to the kids. But
One of our other metrics is adult binge drinking, and while we're not reporting on that one today, that one also has funding from Cats Amsterdam, and there'll be some focus groups taking place in March with our partner with the Speedy Foundation to really dig at what would a harm reduction campaign here look like, such as Booze Less, which has been a successful campaign in Summit County, Colorado. And these other resort communities like ours, such as Summit County, we have the same issues. And so we don't want to do the exact same harm reduction campaign because that may not be appropriate for us. You want to really tailor it, but just so you know, there is some work going on to specifically target adult binge drinking as well.
Okay, so let's move on. I was speaking of our information. All right. So these are constraints. We weren't going to show you all at once, but we'll package them down and talk them through. But our constraints focus on 4 main areas: staffing, culture, dealing with culture change, speed of change or the time it takes to change, and funding. And I'm going to start a little bit on the staffing issue. So one of the things that we have 2 great champions of 2 great work groups right now, and that has allowed us to really launch these 2 and have some good forward progress. But moving forward, we might have some difficulties identifying champions because there's a time commitment with this, and our champions have to take a leadership role, and so they are people that tend to have a higher role in the health system, and so trying to fit this in could be a constraint in the future. We have learned that to run a successful work group, the champion needs support. This is not something they can just say, I'm going to do this thing, I'm going to make this change, and they just do it on their own with all their other workload. and they need support in terms of facilitation of the group, all the stuff that goes with inviting people to meetings, finding meeting space, taking notes, building an agenda, doing all the follow-up that comes out of the meeting so that things aren't lost. And that's a pretty time-consuming process, but it's essential for the work groups to keep moving forward, because everyone else is doing another job too. And then analytics. So we learned a lot from the diabetes work group that you can't just look at the number that you pull out from your query. You really got to explore what's going on so you can determine the best and most efficient area to put your attention, so that it's going to be effective, but it's also going to be, make monetary sense. You don't want to waste money. You just really want to hone in on what's going to make the biggest difference. Competing priorities for staff, and that's across the board. We are taking care of patients, and so that's going to come first. And these work groups are going to come second and be able to fit into someone's schedule. We also have competing priorities within the clinics on different other projects that they might be working on, and is this going to, be a barrier for that? And then the outreach category for staff this is something that we haven't got to yet, but when we start intervening and we want to get more people to come in for mammography or diabetes control, we're going to have to do some boots on the ground, reaching out to the people who aren't engaging to figure out strategies to help them get what they need.
Okay, culture is another one of our constraints.
Real quick, before you jump off, Seb, the champions, would it be fair to qualify? Is that volunteer work sort of for them? I mean, this is outside their scope of work, and are they being compensated, or, recognizing many of them are doctors?
With our VUs and.
Yeah.
They're being, so we want to make sure everyone participating is being compensated.
Okay, good.
So this is not volunteer time. I would say it's still an ask, right? We're
Yeah.
still asking people to do more.
Yeah.
And we can't create more time for them. So, like the physicians who are participating as champions are either using physician engagement dollars that they can apply for, or if they're already a medical director, potentially they can carve out part of their medical director hours to work on that.
Okay, thank you.
The other staff who are paid hourly, we're continuing to just pay them at their hourly rate. We've had to think about well, if this puts someone into overtime, are we going to pay them overtime to do this? So we've had those conversations, but we feel we're making sure people are getting compensated.
Which is a really wonderful segue into, it's a community health index, and we're trying to be an integrated community health partner. However, we haven't quite figured out how to compensate community members to be a part of this work group. So recognizing that everyone that's a top force, we're really intentional with compensating them. That is something we have to figure out as we move forward. We are trying to change social norms. We can talk about the binge drinking for, the rest of this meeting if we want to, but that is a significant social norm that we're trying to shift. And I'm sure you're all aware of the national landscape at the moment. We have 3 really specific metrics that were originally titled health equity, recently changed health disparities, but ultimately at the heart of that is we are trying to change a health outcome when there is a drastic difference between the health outcome of our socioeconomically disadvantaged community members and those who are not. And that's the heart of what we're trying to do. That's why it's a health disparity, health equity, ultimately health outcome metric, but just the national landscape is interesting maneuvering that. And then competing priorities. We are one of 5 peaks. And while it may seem on the surface that we could be competing, I'd like to think that there is some leverage there, that we can find a mutually beneficial way to lift each other up on each of the 5 peaks without it feeling like they're competing. Like you have to take one for this way. I'd like to think we can work together so all 5 peaks can be successful.
Okay, Maria mentioned speed of change or time, but that's a constraint in our work, as in probably everything in life. So we talked about launching the work groups. That is taken a bit longer than we anticipated, right? Coordinating, identifying the people, coordinating when they can all get together, when this is an add-on to their normal job. So that's been a little bit of a constraint. The data piece, again, we talked about this. It's taking longer to get accurate data once we've really dug into these issues. And then how long does it actually take to change that metric, right? So far, we've been talking about building the work group, getting to the root cause of why do we have the problem, trying to tackle what kind of intervention might be successful here in our community. And then we have to launch the intervention and then hope to see some change, and then the metric changes, right? So it's going to be slow, and I think we just have to get our expectations appropriately set around that.
And then the third constraint is around funding, because we haven't really defined the funding for this. So we don't have a real budget, so that makes it challenging to try and figure out how do we prioritize interventions, what interventions are realistic, what can we do. The way that this is set up is because we have to we gather the experts, the work group, determine what the issue is and what the intervention is. We can't really forecast ahead what the result's going to be. What is going to be the successful intervention? And the other thing with that is that's bumping it up against how we budget at Tahoe Forest. So we're in the budgeting process now for fiscal year 26, but we know where the A1C work group is, and we can probably estimate what their budget might be, but we don't know what, say, the mammography work group is going to need, because it's going to take a while for that to build. So that's something that's not working well with how we structure things as a system. And then the third one is, we mentioned that the youth substance misuse and the binge drinking groups have outside funding right now, the youth funding will end in November. And I'm not sure about the binge drinking one. It might be the same thing. So it was like a year of funding. So we have to figure out now, what do we do when those work groups don't have any resources to move forward?
So that has been a great concern of mine in the years that I've been here, is just sustainability of programs. I mean, we have great ideas and we can see where it would make a big difference in our community health, but we don't have the money, we don't have the staff, and we just can't sustain it. So I guess when we look at it, are there areas that we could prioritize and carve out and say, this is what we're going to do for the next X number of years or whatever, and focus, versus having several going on? And I know it's difficult when you look at it, like, what is the most important? And we all have different opinions, but I guess it's just, again, that sustainability to take an issue and carry it to the end, despite all of the challenges.
Okay.
Right, in summary, believe it or not, we're here at the end. Okay, so we did work very hard at defining SMART goals. So as you can see, when we presented previously, these are quantitative goals. They're specific, measurable, actionable, realistic, timely. However, they are very aspirational. So in selecting Health People 2030, who chooses 10-year goals as our guiding light, we chose these 10-year goals and gave us ourselves half the amount of time. So by nature, that's aspirational. A friendly reminder that population level change takes time. So the realistic timeline of a year is actually a pretty quick timeline to identify an intervention you truly think, and you have the data behind you to show that this will be impactful. At the same time, people measure in mortality and longer lives lived, so just to give you an idea of how long it takes. But for that reason, to measure success, we're going to be measuring these intermediate outcomes or outputs, or whatever term you'd like to use, to show that while we may not be reaching this aspirational goal, binge drinking is a huge metric to try to take on. We feel confident we can show progress and that we can show change, even if at the end of the day, we still have a really high binge drinking rate, because they're very aspirational.
What's the definition of the binge drinking?
Binge drinking, Jake, is 4 drinks for a female in one sitting, or 5 drinks in a sitting.
In one
sitting.
One sitting. And that is a CDC definition.
And if you sit all day, then...
Yeah. And then the things that keep us up at night is the staffing. So to get where we are right now, we have just kind of reassigned staff in their current roles to take on new responsibilities. But to move forward, we know that we're going to need some more support, or especially around the facilitation of the work groups and the coordination, as well as supporting community outreach and engagement once we have interventions. And then for the budget guidelines, this one, we need to be able to align our budget with health system priorities, and we need to be able to have some kind of parameters so that we can set realistic projections of what we can do with the work groups.
And then the last thing we worry about is, how are we going to prioritize all this work? We've got the projects and the metrics that we think we want to roll out next or work on next. We know that we are part of a really big health system that has lots of projects and lots of ideas, and a whole project management department where project requests go through and they get approved and they get queued up for who's going to get the resources, right? And we're competing with that process. So that's challenging. We're not quite sure how, these community health projects fit into the larger health system projects. And if we're going to get the support these projects probably need to make a move, make a mark. And then also, let's make sure we're aligning with some of what the rest of the health system's doing. We know there's a lot of momentum for mammography right now from a lot of different people. And so let's make sure we're not working in silos on similar but slightly different things. Let's make sure we're really aligning and working together and doing better that way too.
And that gets us to the end.
More questions?
It's funny, when we went to the Rural Conference a couple of weeks ago in Sacramento, somebody used a quote that I had never heard before, and it was, "The answer is the money. What's the question?" And which I thought was so very true. But I'm wondering if you have worked up any kind of a financial plan. I mean, do you know what it would cost to do the work that you would like to do? Do we know what area we're talking about? I mean, how many what are we talking about here?
We do not have a specific number. We know that we can scale up gradually. Like, it's not like you need all the money all at once. Just like you don't need all the staff all at once, because the work groups are launching incrementally, and so it's a slow build. It kind of depends on, what the work groups come up with. We're anticipating that for multiple metrics, there will need to be some efficiencies or improvements, or I don't know what the right word is, in Epic, and those cost money. How, builds, I guess is the word, maybe to make health maintenance or where we track things more usable across the board. We know that if a work group decides technology is an issue, that's going to cost money, but we don't know exactly what those things.
But you have your goals set out for 2025 in terms of your projects.
For the work groups that are functioning,
Yes.
yes, that's what they're coming. So the diabetes work group, the A1C work group, is really on the edge of really just pulling it in together, a whole project plan, their A1C, and then they will present it, that this is what we'd like to do. And once that's defined, then we'll know kind of how much that was cost. But that's for one work group.
Right, because we're coming up to the budget very quickly now.
And that's the constraint. Because we will have something, they will be primed and I think right in target to come up with a plan that will need to go up in front of the administrative council to see, is this something we can actually do? And we can go from there. The community work group, well, they have some money to get us through this whole issue of education. I think we've got enough funding to do that, but as we move forward and we want to do more things around youth substance use, we'll have to figure that out. And then for the other work groups that haven't been launched, we're starting from ground zero.
As part of the buy-in process, we're trying to be really open-minded, not come into a group telling them what we think the intervention is already. We want it to be a really collaborative process with all those brilliant minds at the table deciding what would be the best and most appropriate intervention. So for that reason, it's hard. If we were to go preconceived, yes, we could give you a number, but we want them, that's how you get the buy-in.
Sure.
And the 12 champions, not just one.
We have a board retreat coming up next week, and I got a sneak peek at the agenda, and community is factoring heavily into that agenda. And so it is a priority, and even looking at things around budgets, but also pulling in, Carly and the foundation, and what's the role of philanthropy in this? What's the role of grants? We see that really up in the air. But yeah, I think that the recognition that, just to say we don't have the money, to say we don't, we're prioritizing other budgets or other activities, that's a direct reflection of who we are to the community. And I'm blown away at the work that's been done. Actually, I personally know how hard this work is, how long it takes. We put that community peak up a few years ago. We started a community engagement committee, as a formal board committee a couple of years ago. Progress can seem slow, but, we sort of move at the speed of life. You know, a lot of this stuff it does take time. But I think acknowledging that, I mean, that's an insane amount of work that's been done since you guys last sat down with us. And when I look, I know the team that I'm looking at here is just sort of a small part of the overall. I mean, that's the other thing that jumps off the pages here is this is not one team, this is not one department, this isn't one health system, right, that's getting this work done. This is a community that'll get this work done. I couldn't be more proud and more excited of who this team is, though, and the passion you have for this work. And it shows in what's been done, so thank you.
Thank you. Thank you.
Putting so much time.
All right. And up next, in fact, joining us for item 15.3, Jake Doris. In fact,
has encryption on it and it doesn't work.
You mean the IT guy doesn't make his IT work?
I don't know, I just looked up all my A1Cs because I haven't had it on my truck.
You didn't go into your mic, on your mic.
There's no HIPAA violations yet.
That's because it's on our network. That's it on our network.
Sorry.
Did you try it on? This is Jake Wardmeyer.
Oh.
Our FBI security specialist.
Special agent. Well, while we're addressing some technical issues here, the intent, just a reminder, we've done this now for I think the last few board meetings, is to pull, most of the board reports are written. We've been working to pull, as time permits and as it's feasible, to pull one of those, really for an opportunity to have dialogue. And the intent here is not just to read what would be a written report, but to really surface items that would be of concern, things that the board should be aware of, the obvious in some of these areas, cybersecurity and those sorts of things. But, so to some degree, it's informational and educational for the board. Where should we be, focusing our energy? But what I really love about the last presentation was the presentation of constraints and concerns, right? We've been pressing that as a board for a while now, like, hey, we hear all the great things that are going on, and there's a lot of great things going on, but it's really important to hear that full story as well, that we have limitations, we have constraints, and when we're making decisions about the board, or about the budget, excuse me, that information is incredibly helpful. So, Jake, how we doing? We in?
That's it. Well, we're going to do it through PDF. So I've got 600 seconds to entertain you. Key trends in healthcare IT and improved pay. So what I wanted to do here, not just replicate my standard monthly bullet point.
Thank you.
Which are incredibly long and comprehensive.
Well, we get a lot done.
Represent all the work being done.
We move at the speed of life, as you said. So we are, this is kind of more of a strategic where we're going, and which is kind of what I think you asked for. So, all right.
Spot on.
Okay, does it go? No? Oh, there we go. All right. So first thing is straight into security. So cybersecurity, advanced threat detection. We're working diligently with renewed relationships with the feds and the local state branches, the FBI folks that are around, as we mentioned. Greg Mortimer, we promoted him from our kind of network guy to our security guy. And he went out and got training and became a actual special agent of the FBI. And he kind of organized that meeting we had at the airport with the FBI guy. He looked like he was 12. So yeah, we're a Palo Alto customer. I think Dale might be the only guy here that when we made those decisions way back when, I brought it to the board and did a whole presentation on moving to Aruba and getting off of the Cisco gravy train, which we're just inches away from doing that. We got a couple more switches. I got to get out of here. So, we've put in very sophisticated threat detection systems with Palo Alto. If you follow Gartner, they're in the top right. They're one of the best in the business. So we're very happy with them. The renewal's coming up though, so we're not that happy in case anybody from Palo is watching. So we also do security audits. We have a partner with Critical Insight. They monitor our website 24/7. So if they see suspicious activity, they contact us immediately. And we also use them for auditing and penetration testing. So we have what's called a white hat team comes in and tries to get into our network unbeknownst to us using hacking tools. And so far, we haven't had any of that. So as well as HIPAA compliance audits that we go through all that every year as well, externally. And we try to switch up the vendors so we're not the same people every year. We do the cybersecurity training. So with the advances in phishing, where you get the fake emails enticing you to click on something, that then infects that computer and shuts down the entire system, we send out our own fake phishing attempts and track who clicks those.
They're getting better.
They are. Yeah, well, AI's gotten a lot better, so they're keeping up. Like the fake stuff is keeping up with the real stuff, so that's good. But we have actually a pretty good, very good, we don't have a high response rate, so that's good. So we've scared people into submission. Data encryption, we've got, as you saw, just trying to put a thumb drive in, wouldn't even read it. Critical measures, so we really have to make sure that data not only data traversing the networks, but also when it's at rest, when it's sitting on a hard drive, has to also be encrypted according to the HIPAA requirements. And that costs a little extra, but all of our drives are encrypted at rest. That means if you went into my server room and snatched a drive out of there, you could not read it. Unless you were the FBI. They got tools for that. Access control measures, so we do all the who can see what, and that's kind of becoming a little bit more important now that we're moving into a new Active Directory world. We really need to work. We're going to have a project with HR to really go through and do what's called SIM, Secure Identity Management. So when a new employee comes in, they have a job code, and that job code gets X, Y, and Z. And then when that person wins the lottery and leaves here and they're no longer in payroll, it'll say, hey, Jake's not here anymore, take him out, disable his account. So it's all kind of automated, because that's difficult no matter where I've been for 20 years. Unless I had SIM and CHS, it was easy because it just happened. But yeah, access control, role-based access controls, only people that can see the things that they need to see can see them. It's harder in a smaller hospital because many people wear many different hats. So you're like, well, I also do payroll, but you don't want people doing payroll that's also doing like AP. That's also, like I could create Jake's lawn service company and submit an invoice for $2 million, pay myself, and down to Belize. Disaster recovery is a big deal. So cybersecurity threats, disasters, we've seen, we're in fire country out here. What do we do? What's our recovery plan? And we have off-site storage. Luckily, most of our important applications are hosted in various regions of the United States. We want to keep minimal disruption to patient care, and that flows into business continuity plans. So if we know we're going to be down for an X amount of time, how do we get back up as quickly as we can? And that's kind of been the mantra in healthcare cybersecurity for years, is like, it's not if you get hacked, it's when. And really what you need to prepare for is not like prevent as much as you can, but have a plan. So when it happens, you can get your business back up and running as fast as you can.
Do we have policies on, ransom, those sorts of things?
Like recovery plans?
No, like, do we pay it?
Oh, I'm not paying.
Yeah. We have enough
Have
backup.
to ask Special Agent Greg.
Well, you've heard,
FBI doesn't want you to pay.
okay, I mean, but you heard, I mean, clearly there's plenty of national stories of, I mean, literally crippling
Yeah,
health
oh, yeah.
systems. Yeah.
City of Truckee.
Chucky had it,
Yeah.
but they didn't have what I got. So I've got systems that take snapshots of our systems and store it off-site pretty regular.
Regularly, yeah, yeah. Okay.
So if we had to, we could go back to, you basically got to go back to find out, because sometimes they'll put the malware on and wait.
It was 6 months ago.
Yeah, right. So then you got to start backing up. Let's get the, ain't no paper, no more. AI and digital transformation, I know that was something we talked about. My personal, I think AI is going to change a lot of things, clearly, but in healthcare, I think it's going to come a little slower. But what I've kind of settled in my, because I get literally 40, 50 emails a day from, hey, we've got an AI, blah, blah, blah. I'm sticking with Epic. Epic is on the forefront of, they're enhancing and putting AI in just about every single module they have. It's just coming at a slower pace. So we went live with a couple of AI products with them already. We've tested out DAX, which is Nuance's ambient listening product. Dr. Koch and Sam Smith and some other physicians tested it, and they said they liked it. The barrier to entry to that is going to be $1 million probably to put it in here, literally. And so that's it, that's part of AI, but that's a partnership between Microsoft and Epic, because Microsoft bought Nuance. We already have it in mammography. Our DI stuff is AI. Some of it's AI driven, and we tested out an AI fall risk module in Epic. We struggled at first because it was like, everybody's going to fall. But we were able to work with Mercy to turn the dials a little bit, to turn it down, and now it's okay. They've asked us, Mercy has asked us to come along with them on this nursing documentation journey. It will look through all of the nursing documentation and create like notes for the nurses that they can read and edit. It doesn't automatically go in, but it condenses things down. And that's brand new. Like they're beta. Mercy has a very good relationship with Epic, and Epic asked Mercy to test this new nursing documentation AI stuff out. So there's plenty of AI innovation coming out of Epic, and the thing with me is like I know it's going to work if it's coming out of Epic. If I have to buy some AI third party or I get sold it, then I've got to pay implementation, I got to pay integration fees, I got to work with Mercy, and Mercy might be like, man, it's like 6 months from now, we're going to be doing this in Epic. It's like, what do you do? So I think I've kind of decided just to stay with what Epic's bringing. Clinical decision support's coming, that's AI driven, so that's going to help providers. And also administrative process streamlining, which will help hopefully cut down some of the pajama time and help get physicians back to patients and out of the computer. Help with paperwork, improving operational efficiency, et cetera. Scheduling, billeting. Patient outcome improvement, hopefully, like we've seen with some of the other AI tools, like the sepsis tool, like it can predict, like the A1C, like who's going to get predicted to have a dire event. Like that's where the power of this stuff comes in. Patient portal enhancements, those are also coming our way. We have some that we're getting ready to turn on, but like I think Dale, you said you use some of it now, the fast path or save your seat in line. The on my way stuff that you said you were.
To the urgent care.
Yeah.
Oh, yeah.
So those are new tools that are coming along. Patient self-scheduling will come through. That's got an AI component to it because it'll look what's the best next available slot for you.
Yeah.
So we want to kind of live on that new edge on my chart. Mobile health applications, those are also coming. Epic's going to start, well, they already do. They offer with third-party vendors, like you can link in to launch virtual sessions with patients straight from Epic. Remote monitoring technologies, I don't know anything about this. You got anything to say about that?
Let me think. Yeah.
Well, this is getting even more and more just ubiquitous in the world. And they're super easy to connect to. Everything's Bluetooth, or, all you need really is a code to connect to blood pressure monitors, barometers, scales, glucose readers. Looks like this cat's getting EKG.
Are we taking advantage of this now?
No, but I'm saying this is kind of on the roadmap.
Yeah.
So if I have a smartwatch and he has a Fitbit and they're collecting all that, there'll be something at some point in the history of Tahoe Forest that will have something that.
Called
Blue Life. Yeah.
Well, I thought that we had blue light and
We did.
it went away.
It did.
It did.
The wellness neighborhood killed that. Oh, you weren't there then. Your other two cohorts. But it was ahead of itself.
It does
But
come
it-
into a question, though, of kind of dovetailing into the last presentation around Community Health Index and whatnot. What role do you see technology potentially playing in a lot of those initiatives?
Well, this, like, A1C, continuous monitoring.
Yeah.
If you've got patients that you think are not handling that, then you can monitor it. And that's what they do in the big cities. Like Chicago has those programs all over the place.
Yeah.
It's like, Jake, your A1C's creeping up. What are you doing?
Yeah.
Eating a donut? Smoking a cigarette? So like those types of interventions are happening now. And there is a ton of diabetes research on community interventions.
Yeah.
Mississippi started it years ago with Meditech. So it can be done. A1 powered diagnostic tools, or AI powered, A1, I'm thinking I'm hungry, I want a steak. Diagnostic tools like the imaging solutions we talked about, predictive analytics, improving diagnostic accuracy. I think those, we're already doing some of those, but it's going to get more and more. As more, the FDA's kind of have to approve some of these things to say it's safe. And they have with the DI, not all DI, but, the things that we have been able to implement, so.
Are we, with Hologics, we're a pilot side, aren't we, for some of their, pilot side is the right
Said we
term,
were,
but,
I don't know.
yeah, okay.
We were the first.
To put it in.
Yeah.
Yeah.
How soon will AI do a first read on radiological images?
Legally,
Yeah,
it's doing it now.
is it?
Yeah,
And simple ones.
Yeah, well, all of them. There's universities that are building these programs that are allowing it to do first read, and then it says, here's, out of these 5,000 reads, here's the 150 we think are dangerous, so go pay attention to those.
Yeah.
And that's kind of where this is, like, it's not gotten to the point where you just turn on the computer and go play golf.
Yeah.
But, that's the fear.
So the idea.
And the hope, I guess,
It
both.
would be that instead of us going to VRAD overnight, you could plug it into an AI site.
Yeah.
Get a read, and our staff then read.
You get like a wet read from the AI.
Yeah. And is that soon for us, or?
For us, I know it's when the feds say it's okay and you can bill for it, then there's a big difference, though, right now. It's like the,
Yeah, it's already happening actually now when we send our images at night to VRAD. The AI systems are already reading those scans initially, but then they're always also read by a person.
Yeah.
So the radiologist reads them, gives us a preliminary read, and then we actually do a final read the next day with
So
our
there's
radiologist.
three reads
There's
then.
three, AI, then the guy that's at VRAD, and then our guys.
VRAD is one of the leaders in artificial intelligence in that space. I was kind of, like, when we had that old VRAD thing, I was looking at their list of modules, I was like, wow, they're doing a lot.
Could I just
Yes, go
ask
ahead.
Dr. Evans to also talk about the mammography AI?
Yeah, I mean, well, that's what Louis just mentioned, the Hologix is, we're the first site to use AI Hologix here, and we're still doing it now. Dr. Schlund has actually been involved in the development of that technology, so.
That's why he wanted it.
And we're a front runner on that one.
Yeah, cool.
So, really proud of that.
Which is, yeah, like, that's pretty cool.
Really proud of that.
I mean, when you think of all,
Little Tahoe Forest.
little Tahoe Forest.
We ain't little. EHR and ERP optimization. So we're also looking at how do we do data interoperability improvement. We've joined several HIEs. The latest is Sac Valley MedShare, which is a QHIE, federally qualified, which is a new standard that everybody has to be part of. But that will help in, if I have a patient that shows up in Sacramento to the ER, it will let me know, hey, your patient is in the ER in Sacramento.
And will it happen the other way? What I've been getting information from some of the residents in our community who come here is they have to get followed up in Reno for whatever the x-ray showed, because we can't do it. And yet, once they get there, they have to cancel the appointment because the information wasn't sent. She comes back to our hospital to find out why it wasn't sent, and they go, no, we sent it. So somewhere that
Reno sounds like
it's an electronic, it's not being read somewhere.
Well, we're not making appointments through this system.
No. She already made the appointment in Reno to be followed up with her x-ray.
Yeah.
She assumed that the x-ray was sent because she asked it to be sent
Do you
there.
know, was it Renown? Because we share information with Renown, but like the Reno Diagnostic Imaging,
Yeah.
we don't.
I don't know. It wasn't Renown, I know that, because that was the first thing I asked.
Yeah, we do with St. Mary's in, now that they're on Epic, or getting there.
But do we ever ask the patient where are they going to be seen at?
Yeah.
Because that would
We
also.
also send, like, if we send it down there, we'll give them a disc.
That's why I didn't
Oh,
understand why, if it was someone we can't communicate with, why a disc wasn't given to
This
her.
wasn't,
And it's not for you to answer, I know. It's,
well, I mean, PACS is different.
yeah.
So I'm talking about just a general, hey, Jake's in the hospital with, he shot himself in the hand with a nail gun. Right? So now, Dr. Trudell, who's my PC, would be alerted to that. You know who uses that a lot and asks a lot is Dr. Koch. I wish he was still here, but she really is hot to get that system set up because she sees a lot. In incline, she sees a lot from all over.
In addition to being alerted, that would you then be able to see what was going on?
Yeah. Yeah, you'll send it's a pretty robust feed to the Sac Valley MedShare. And they even have an app to go in and look at those things. So.
Does it work with a VA?
Nothing works with a VA.
Are you sure? But if that would work with our other regional hospitals, to your point, that would make it that would solve that patient's problem.
Yeah. And it's not just one patient's been, yeah.
Yeah, I just assume they don't have my stuff. So I think that that's the goal, right? And to have a federal register, and that's what that qualified HIE is, like the feds are saying, there's a specific way you need to put this data in. And then once we get all that, then we can tie it all together to one. If we could just use social security numbers, it wouldn't be a problem. But that's one thing the government will always agree on, both sides, is that you can't use a social security number for identification. Workflow streamlining, we're also working with that. Epic has created a bunch of classes, actually, on their Epic user web, and that you can take in bite-sized chunks that will help physicians see how Epic thinks the right way to do things is. Because in any EHR, there's usually 35 ways to skin a cat. So this can help with the providers. And we also have elbow-to-elbow support through the IT department. And we do offer that to any physician that wants it. Enhancing system performance involves regular upgrades, so we have regular upgrades. So we moved from that yearly monstrous update that was down for hours and hours. Now we do them every quarter, so we get smaller and less impactful downtimes and get the updates as they come from Epic. Data analytics for decision-making is another topic on our list, not just for clinical data, but for financial data and, looking at, should we build this, should we not build this, is there volume to support this, etc. Talent management challenges. So, it's hard up here to get folks. I find people with the talents all the time, but they're like, how much is the house up there? And I was like, well, there's always rain. So it's a struggle. So like we had a really good candidate that we were going to put into the role, the previous, and he was almost there, but I couldn't get him.
What's the importance, on-site versus remote versus?
Depends on the job, really. Like,
Yeah.
if you're going to do elbow-to-elbow support, you kind of need to be here.
Yeah.
And the whole point of that, like, the way I've seen it work best is, like, that person sets a week. This week, I'm going to be working with these 3 docs, and you go sit with them for an hour or 2 each, and really kind of watch them through a couple of patient appointments, and just see, okay, and make notes, and then maybe another day of that. And then come back on that third day and say, oh, I see you've done this, this, and this. Here's some areas I think could help you, and let me show you how I would do it.
Yep.
And then that's important to be on site. A lot of the other, 95% of the other stuff can be done remotely.
Okay.
Except for like break fix. My printer's jammed. I've gotten up at 3 in the morning and go to hospitals, take a piece of paper out of the printer. Happily did it. And then how do we keep folks here? I don't have a big problem with people leaving, and the ones that did leave, I wanted to leave. So, but, I've got really strong employees, and I want to reward them in ways other than just financial. And so I think that working with career ladders and, other titles perhaps within the IT department might be cool. Training and development programs, we offer a lot, like I just said. Special Agent Greg Mortimer went off for that training. I think he's got 2 or 3 others that he wants to go to. I was like, go do it, man. We have a lot of Citrix guys, specialty softwares that they're experts at, and I'm like, stay certified, stay on top of that, because you're no use to me if you can't. If you fall behind, no good.
Job. Yeah.
And then again, I just rounded out on cybersecurity vigilance. They're evolving, and it's getting a lot easier for them to gain access, and they have, and they're all over the news. So it's, again, if or when, just mostly when. So we have to prepare for that. And we can't ever stop saying we've made it.
Right, we're safe.
We're safe now, like we're not going to be. So we moved back to paper. We could. Shh, don't say that. So we are also continuously investing in the infrastructure. Like the Palo Alto is coming into life, so we're going to have to re-up or switch vendors. We've got, Dale was here when we made the decision to swap out the entire network and put Aruba in. That was 7 years ago, so some of that stuff's now. We did realize the savings, though. It was a lot of money, and just on support. So now those are kind of coming to the forefront of figure it out now, so we don't have to do it all at once. And then I gotta get put in the sleeper hold by Crystal.
Yeah. I'm just gonna say.
You don't need that. Go to sleep. And then improving the hiring process. I think we talked about it in the onboarding.
Yep.
Did that come up? We talked about onboarding. Just improving it, because we got a lot of, like doc start, we've got paperwork we got to submit to Mercy. Mercy's got to get all through that, and then make sure we're checking all the boxes. We had one doctor that started that had no admitting privileges. And they were like blaming Mercy, and I was like, show me what we sent them. And it was a box in Excel that said, admitting privileges? No. So that's on us, that's our bad. So trying to help smooth that process out, as onboarding, hiring, and make sure everybody gets that. That will also help with that identity management. Oh, they're a 402, that's this kind of doctor, and they work in the ER, they need admitting privileges, and it just all goes. And that, I think, is it.
Question.
Yes, sir.
Our buildings themselves are pretty well hardened against fire danger.
I don't know. You got a lighter?
I'd like to think they are. But if,
Dylan, though.
but the smoke could make us have to evacuate if it got really bad.
Yeah.
And if we moved our people off-site to renown
Patients.
patients,
Okay, yeah.
I don't know, there may be physicians too who would then go down to Tahoe, whatever. What's your coordination with handling that situation, if any?
IT-wise, not much. Like we could get, so what we have here on site is called BCAs, it's backup computer appliances. And you'll see them on the floors, they got the red keyboards. So if we lose connectivity to the rest of the world, because remember, our EHR is stored in St. Louis.
Mm-hmm.
So if the fire is raging here, our data and everything's still safe in St. Louis.
Yeah.
But if that connection is ever severed by a fire or whatever, we can still get to those patient records, the last known records that we had. It keeps like a local copy of it here.
Yeah.
So we can still get to that through that BCA. And then if we had patients, we can manually print all of the images, like we keep, I don't know what it is, 90 days on site of diagnostic images here before it goes off to long-term storage in the cloud. But those hospitals down there could pick up.
It could.
Yeah, our images. We're moving to the Sectra product called a VNA, a vendor neutral archive, which allows you to share it a lot easier with other folks. And it's cheaper because now we don't have to maintain the storage here. We can just throw it all onto the cloud quickly.
Right.
But we could also, like, from that PAC system, if it's awake, we can make copies on DVDs of those images if they needed them.
Yeah.
I think most of them are going to take new pictures of them when they get down there anyway. Nobody trusts anybody.
Yeah.
I know I would. Be like, yeah, let's put you in this one. Although our MRI is high end,
Yeah.
so we get compliments from
The highest end now, yeah.
no, France has got 11T. You can see into the future with it.
I'm going to push this along because we're
Yeah, I'm
actually
good.
not very late. But one, thank you for the update. I mean, it's always this stark reminder, like how broad the scope is, from like literally pulling paper out of printers to cybersecurity. Like IT touches every part of this business. So thank you,
Yes.
Jake.
Good. All right. Thank you.
Great stuff, thank you.
We have one item this evening for under board action. Ted Owens, welcome.
Chair McGarry, is this on? Can you hear me?
I can hear you, but I don't know if you got a red light.
There we
You're
go.
on.
There we go.
You're on.
Thank you. Chair McGarry, directors, good evening. Ted Owens, Executive Director of Governance. The item before you right now is Resolution Number 2025-05, which is a resolution opposing federal funding and staffing reductions that impact forest health and wildfire mitigation. It is within your purview to entertain such a resolution. I'd like to give you a little bit of background. This was initiated by the town council, Town of Truckee, and who passed the similar version of this resolution, with the idea that they would work to seek other governmental entities, special districts, perhaps counties, to join them in the passage of this resolution. The collective resolutions would be delivered directly to Congressman Kevin Kiley in his office, and I believe that'll happen on April 18th. And so that is the background of where the resolution came from. The staff recommendation would be to approve, and I'm here to answer any questions that you may have with respect to the resolution.
Do you know who else is signing this?
Good
Or their form
question.
of the resolution? beside the town?
Director Wong, there have been several local agencies that have passed a resolution or a version of this resolution. I do not know the complete list. I do know, say, the Rec and Park District did. I spoke with the general manager over there. I believe the Fire District did as well. The thing about this is we do a lot of work with our OES partners in tabletop exercises on wildfire disasters. We've done them here, evacuation exercises and things of that nature. So this directly speaks to some of the preparedness work that we do. And the resolution seeks to have a restoration of the funding that is at risk for the Forest Service and others that protect our region, both with mitigation efforts as well as forest fire fighting. So I can add as a personal note, in past experience and education with the Forest Service, I've considered them undermanned and underfunded for the past 3 or 4 decades.
Yeah.
So this is a critical issue to our region and one that shouldn't be taken lightly.
Do we know where Mr. Kiley stands on this?
I think we will know. Actually, Mr. Kiley's he's been very open to these discussions up here and has some great respect for this region and what the concern is. But I think we'll learn a lot more upon delivery on the 18th of April. I intend to be there.
What about the group from DC that comes out here annually to the lake and talks about preserving?
From the Tahoe Fund.
Yeah, the Tahoe Fund and the others,
Certainly the Tahoe Fund and others, I can't speak for them, but their support level for these types of measures has been strong, but they're not a governmental entity, so they've not been asked to pass a resolution like this.
No, but I'm thinking of John Garamendi and others who come out and participate in these events. They're connected.
Yeah.
Deeply connected to the Lake Tahoe area. Should this go to them too?
Well, I think that is a very good question. This is being spearheaded by the town. I'll make that recommendation if you like. And if not, I'll personally see to it that your good friend, Mr. Garamendi, receives a copy of the full load.
Or any of our other representatives.
I have the same question. I don't have the answer to that because I think that this should be delivered to our U.S. senators as well. I think they would be very supportive of this.
Yeah.
Questions? Yeah, I mean, I always find these sorts of things interesting. You might think straight off the bat, it's sort of outside of our primary swim lane. Like, what does this have to do with healthcare? But as presented, it's kind of sort of right in the heart of who we are as a member of the community, right? And clearly, should there be a large scale disaster around forest fires, impacts us in ways we can't even quantify.
Potentially, it could impact in ways that we witnessed down in Paradise.
Yeah, absolutely. Yeah, absolutely. So
it's in your lane.
Yeah. If you like, I would be happy to make a motion to approve resolution number 2025-05.
Chair, may we ask for public comment first? Thank you.
Thank you.
You thought I was here just to observe.
Sorry to keep you so late.
You're approaching my bedtimes. For the record, my name is Deirdre Henderson. I am a resident of Truckee. I'm the co-lead of the North Tahoe chapter of Citizens Climate Lobby and co-lead of 100% Renewable Truckee. I am a patient here, as are 3 generations of my family who live in Truckee. I'm here to support this resolution. I think it's very important. I, as you know, have been a climate activist, a climate advocate, lobbying Congress primarily for the past 11 years. I've been to Washington every year to lobby Congress. I lobby in district. I have lobbied dozens of congressional offices and members. I've built relationships both in upstate New York, where I used to live, and here with a senator and my three representatives, the three representatives who have been my personal members of Congress. One of the things that we have learned over time, and we study this and train on this all the time in Citizens Climate Lobby, is how important or what kinds of groups congressional offices are particularly influenced by. And I can tell you that publicly elected officials get a very good hearing in congressional offices. We love to take an elected official with us to meet with a member of Congress. Your resolution, because you are publicly elected officials, will be paid attention to. And as for our member of Congress, Congressman Kiley, there is currently in Congress a bill called the Fix Our Forests Act, which has many different provisions, but generally it is to improve the health of forests in an effort to mitigate the vulnerability to wildfire. He has been a co-sponsor of that bill, actively supported it, got it to pass, helped to get it to pass on a bipartisan basis in the House of Representatives. It's now awaiting action in the Senate. So I think that this resolution from an elected body will be of particular influence, especially with all of the other elected bodies that are signing on to a similar resolution. So I would suggest that I assume you're going to do a cover letter for this when you transmit it, and I would suggest that you make sure that Representative Kiley and our senators know that this is a public health care district and that you are an elected body. I think that will enhance the resolution. But please do pass it. This is very, very important. Thank you.
Any other public comment?
Then I will move that we approve resolution number 2025-05 regarding the opposing the federal funding and staffing reduction that will impact forest health and wildfire mitigation.
I'll second that motion.
All right, motion and a second. All in favor?
Aye.
Opposed? Resolution approved, 4-0.
And remember that cover letter.
Of course, I'll be running the chair down for his signature on that, so.
And Ted, why don't we just keep you in the chair, because we do have a few items are pulled from the consent calendar. We'll since you're in the chair, we'll just go in reverse order. So 1471, around a ballot selection of Placer County Special District representation at LAFCO.
Well, I'll fall on the sword. I own this. I should have put a cover sheet on this so that you understood the background. So I'll just present it very quickly. I did have a conversation with the chair about LAFCOs and what they are. So briefly, LAFCOs are state mandated bodies. They're quasi-judicial in nature. They were developed in the 1950s when California was really growing at a rapid rate. And there was no regulation over how it grew. So sometimes cities established boundaries that overlapped each other, or special districts, fire departments did the same thing. So it was a bit of a mess, and they created what are called LAFCOs. When the chair asked me about this, I did tell him, it's not a comedy club.
Yeah.
Okay, it's the Local Agency Formation Commission. And they are represented with a body that consists of members of the Board of Supervisors, the county that it exists in. There are also city council members, a certain number of city council members, and there is also special district representation, and usually one member of the public serves on the board as well. And these are bodies that we're kind of a square peg in a round hole with respect to LAFCOs. Hospitals have evolved, hospital districts have evolved. We're a little bit different than other things, but let's just say a city has a city boundary. That would be approved by LAFCO. They would also have what's called a sphere of influence, which is an extended boundary that it tries to drive logically where growth should occur. Cities may choose to annex parts of that and bring it into the boundary of the city. These are the types of things that go through LAFCOs. In addition to that, and our LAFCO is, I don't know how many years out of sync with this requirement, but we should have a municipal services review coming up soon, and that's done through LAFCO. Now, our LAFCO that we are in is Nevada LAFCO, or Placer LAFCO, excuse me, which may seem a little bit odd to you because we're domiciled in Nevada County. The reason is when we have multi-county districts, the determination is made based on the valuation of property values or property value assets, and Placer County has a higher asset level, and that's what drives us to be under the guise of Placer LAFCO. We have the opportunity to elect representation as a special district, and in this particular case, and I think we should do this, we have a candidate in Judy Friedman. Many of you know Judy. I know Dale does. She's a director with the Tahoe City Public Utility District, very active over at the lake through the years, and she's a candidate for the special district seat. The reason I would, not only on her own credibility as given her public service and her community service, it's very important to have representation from the eastern reaches of Placer and Nevada County. And therefore, we don't have LAFCO-related decisions made entirely by representation from the western part of the county. And with that, I will leave you with a recommendation that you place in motion Judy Friedman, as our vote for election to the Placer LAFCO.
Judy is well-connected and well-experienced, and she's got a long history of involvement in these types of things, so I'd highly recommend her.
And she's been the interim since Rick Stevens stepped down, and so she's been in the position as well as doing the job.
Thank you for pointing that out. That's correct, and it's important because learning LAFCO is not as easy as it sounds, and it's challenging.
You want?
Well, just a comment more on process. It wasn't even clear to me what we were doing with the information that was presented to the board. Very clear now, with your description. But in the materials that were presented, it wasn't even clear that we were voting, that there was a recommendation for a person on the list, and then there's only, and I recognize there may be only 3, candidate profiles that were created, but it made it very challenging to understand and approve this under a consent agenda. So,
Point taken. My fail. I didn't include the cover sheet, so my apologies.
That would have been helpful. Any public comment? No. Then we'd be looking for a motion.
I'll float a motion to endorse the election of Judy Friedman to the LAFCO.
I'll second the motion.
All right, motion and a second. All in favor?
Aye.
All opposed? All right. Thank you, everyone.
Thank you.
Approved 4-0. We had one other item pulled from the consent agenda, the financial report. Hi, Crystal.
I thought because of the size of the variance that we had in the financial statement, that it would be of value to hear a little further about
What's going on?
Discount allowance, contractual allowance.
Yeah. So through Finance Committee, we've been talking about this for a while, but we have been going through a transition quite a bit as an organization. January 1 of 2024, Partnership Health Plan came into our counties, and they were definitely a different plan to work with than our previous ones, Anthem Blue Cross and California Health and Wellness. So it has taken us a while to get our systems and our claims to operate properly from that perspective.
We had been working with 2 vendors that were not meeting our expectations. And so we had chosen to separate our ways and had gone through a selection process and picked a new vendor to assist our business office. So we've been going through that transition. Over the months, you might have seen the AR days climbing, and we're finally getting in a position where we're being able to make an impact on our AR again. Part of that is cleaning up old AR. And when I say old AR, it doesn't mean that AR was necessarily collectible. And I'll give a very brief example. So our partnership claims, when they would come in, we'd get a payment and an adjustment. Our system was taking the payment and posting it, but the adjustment, it wasn't identifying as a contractual allowance. So it was just putting it as information only, never removing that contractual adjustment off the account. So we had balances sitting on the AR that had always been intended to be written off, but never were because of a system hiccup. When we record reserves, we have stopped using a 100% reserve methodology. We have watched for years now, when we end a fiscal year, let's say we said we're going to collect $40 million. We watch over the year our actual collections, and we have found that we were reserving too much on that 40 million because we were collecting more than that. So that meant our reserves were too conservative, and we had to adjust accordingly. So when we have a balance sitting there in an old category, it's reserved for at a lower percentage than 100%. But when it's actually 100% uncollectible, like a contractual allowance that's sitting there, when we actually take it off the books, it impacts that contractual allowance line because there's extra dollars being written off at that moment. So as we clean up AR, we are going to see some spikes in our contractual allowances for those accounts that were never had a collectability factor to it, that were only reserved for at something lower than 100%. So you're seeing a little bit impact of the cleanup of the accounts receivable as we work through the trail out of the old Medi-Cal managed care plans, the new Medi-Cal managed care plan with partnership, the transition of the vendors that were assisting us with both the commercial and the Medi-Cal managed care space. And so as much as that may look like a negative, it actually isn't. It's actually a positive transition to really bring the accounts receivable down. It will focus more on current AR than older AR, and that's the position we want to be in. So that's what's going on.
Thank you. Thank you, Crystal.
Sure.
And I got a sneak peek this afternoon of our current AR situation, and it's improved vastly.
Yes.
And look forward to more cleanup. And
we hit our peak, I think it was in November, at 75 days, and I remember telling my team, please don't panic. There is a plan. We are going through a transition. We were at 61.2 today. So
61.2?
Yeah.
So we're making some great progress.
Wonderful. Thank you, Crystal.
You're welcome.
Any other questions?
No, but
No?
I would move to approve.
I think we got to go to do we go to the public? I think we got to go to the public. Audience comment? Nope. Since you polled, since you polled it.
Since I pulled it, I would move to approve the financial report as presented.
I'll second it.
All right, motion and second. All in favor?
Aye.
All opposed? All right, thank you. Approved 4-0. All right. Those are board committee reports. I'll kick off one on the foundation because it could be really brief, and it's an admission of my failure. Between different jobs in different cities, I grabbed the wrong notebook, and so all my notes about the foundation meeting are sitting somewhere else. So I will bring it next month. One of the big changes, they're meeting quarterly now with committee meetings on a more monthly basis. So we'll be here, for that reason, won't be getting updates as much, but I'll I'll do my best to bring it next month.
And I failed to attend the Incline Village Foundation.
We are a winning board, aren't we?
Because
Yeah.
I was at the California Hospital Association.
Okay, fair enough,
Held a
fair
big
enough.
conference.
I wrote down a couple of things from the CHA Rural Healthcare Conference. I only started writing down some of these quotes when I heard the one that I repeated earlier about money's the answer, what's the question?
What's the question?
But this will give you sort of an idea of what happened at the conference. So money's the answer, what's the question? Strategy follows reimbursement. Stop shrinking to fit.
Yeah.
End-stage poverty was mentioned several times.
End-stage poverty.
Yeah, I thought that was an interesting way to state it. Community development is the tide that floats all boats. We can't get to an enhanced future by damaging the present. Whoa. Focus on what's possible versus what you want. Notify, justify, modify, report. This is great. This should be last, but it's next to the last. Your immediate boss has a greater impact on your mental health than your spouse. Think about that for a minute.
You haven't met my spouse.
It's not how many people you lead, but how many leaders you grow.
Oh, nice.
Yeah.
Anyway, those were just a few quotes that I pulled from the conference, but as I say, there were some that preceded those, but when I heard the one about what's the answer, I started to jot them down.
Yeah. That's great. I'm glad you did. There were some chuckles there.
Any other committee reports or closing remarks? I have one then. Thank you, everyone. We went a little extra long tonight, but I think it was for really meaningful updates of some incredible work being done in the community and within our organization. So I think it's wonderful to create that space to share. So, but thank you, everyone, for some extended time tonight. Appreciate that. And with that, we'll adjourn. Thank you.
Thank you.
See you all in a few days.
And I'm going to remember getting out of here at 11:30.
Wow.
So,